Dear friends, very good morning on this chilled Sunday. I am Subhranshu Mohanty, President of the Bombay Orthopedic Society, and welcome to its fifth e-clinical meeting for this academic year. As you know, we have conducted all our academic courses and clinical meetings, master cares, etc. on virtual platform this year because of the pandemic, and it has been hugely successful. All our courses are oversubscribed, all the clinical meetings are well attended, and the beauty is that we could involve all the people from outside Mumbai, even outside India as well. So today, the fifth e-clinical meeting is being hosted by one of the premier institutes of this country, the Grant Medical College and Sir JJ Group of Hospitals, the Department of Orthopedics, headed by Professor Eknath Pawar. Professor Eknath Pawar will be joining shortly. Since we have large number of cases to discuss today, we'll start with the clinical meeting. May I request all the presenters to please hide the faces, or please don't disclose the identity of the patients you are presenting, because it's a virtual platform. Bombay Orthopedic Society doesn't take any responsibility if any eventuality happens because of that. Number two, we have we welcome all our expert group who has been there on our Zoom platform to generate discussion out of this case, and especially the past president of Indian Orthopedic Association and an esteemed member, Dr. Sudhir Babulkar, and along with him, there are a panel of experts like Dr. Hitesh Garg and Dr. Mukhi is there also. So I thank all our esteemed panelists for being present there and on this Sunday morning and devoting their time for this academic discussion. I request all the experts, just please don't unmute yourself unless I ask you. Of course, the control is in my hand, so that prevents the overlapping and chaos on a virtual platform. So when I ask you to unmute, please unmute yourself, or if you want to suggest something, then you can raise your hand or press option Y on a MacBook or a control Y on your Windows book. So then I'll unmute you. So without wasting any time, let us go ahead with the first case presentation by Dr. Dheeraj Sonone. May I request Dr. Dheeraj to to present his first case?
Yes, sir.
I think Dr. Pawar has joined. Welcome,
Yes,
Professor Eknath Pawar. Thank you for hosting the clinical meeting today. Can I have a few words from you?
Please unmute Dr. Pawar. Please unmute Dr. Pawar.
Yeah, I have asked him to unmute.
Sir, please unmute yourself. Yeah, he's now the co-host.
Yeah.
He has to unmute himself.
Dr. Pawar, can you unmute yourself and just say hello to our viewers? I think there is some problem. Okay. Okay, we can go ahead with the presentation. Dheeraj.
Okay, sir. So I thank you, Bombay Orthopedic Society, President Mohanty sir, President-elect Sangeet Gawale sir, Secretary Swapnil Keni sir, for this wonderful opportunity. And I will welcome all the delegates to the BOS clinical meeting at Sir JJ Hospital. I will like to inform you that JJ Hospital has completed 175 years in this month, and it is 175 years of medical education and patient care. So I will start with my first case. It is a failed fixation in a congenital kyphoscoliosis with a severe deformity. So this was a 7 years old child with a hemivertebra and a juvenile onset structural proximity. And You can see on CT there is a hemivertebra there. Obviously, we have to plan for a hemivertebrectomy. The MRI was normal in this patient. So this was our single level fixation done just to preserve long segment fusion and prevent growth. Hence, we have done a single level fusion, done a hemivertebrectomy and grafted this patient. She was also having a syndrome, Turner syndrome. Yeah, so this was signs of early failing. So she was failing to unite, though the implants was there in situ. So this was the collapse at 1 year. There was no signs of fusion. On the right side, you can see at 1.5 year there was further worsening of collapse. Still, there is no signs of fusion, though the implants are still intact. And yes, this is what happened at the end. There was further collapse and dislocation. You can see the yellow line, which is the anterior border of the upper vertebra, and which is just in completely in contact with the upper end plate of the lower vertebra. So there was almost a 90-degree deformity in kyphosis as well as scoliosis of 90 degree. You can see on the right side there is a broken screw and which is cut out completely. So these were the CT of this patient, and this was the clinical picture. You can see the all the implants is prominent, is less soft tissue there, and there is a significant deformity, and patient is neurologically completely intact. So the challenges in front of us were there was severe deformity, there is a poor soft tissue in a small child. There was fibrosis posteriorly as well as anteriorly since we have done anterior hemivertebrectomy. Patient was completely neurologically intact. There was a poor bone healing tendency as well as the bone was very soft, what we experienced during first surgery. And we have to preserve her motion. So tackle each of them for correct, we have to correct the severe deformity. For a poor soft tissue and getting a better hold, we have used a low profile but an adult screw set because to handle the fibrosis there, we won't able to see the dura and the anterior. We have to reconstruct the anterior part by taking out all the fibrous tissue. We have to use a neuromonitoring for that and large screw for better hold and better anchorage. So this is what we have done. Yeah. So we have done a 3 level up and down fixation. We have done anterior reconstruction under neuromonitoring guidance. We have taken out all the fibrous tissue. We have got a better hold in the vertebra this time with a bicortical purchase, dual thread system, and low profile adult screw. And the deformity was completely correct in both the planes. Though she was having a proximal deformity at this stage, and these are the clinical pictures of this patient. This is 1.5 year follow-up. Just we have operated her 6 months prior to the lockdown, and this is a 1.5. You can see there is a significant prognation of the proximal curve. In the next stage, we are planning to correct this proximal curve in a single and a definitive surgery has been planned. Thank you.
Okay, Hitesh, what is your take on this?
I think I would like to go to the first when the child was 7 years old, the first X-ray, and
Yeah.
we have to find reasons why we are keeping. I mean, we are missing the bus every time. So the reason I think is we are focusing too much on only hemivertebra. So so if I analyze this case, I think we would have to go why did the fixation fail in the first place? Did we do the right thing? And what should we? I mean, in retrospect, of course, we are always wise. And should we have done something better? So if we look at the first X-ray, can we go to the X-ray before this? Yeah. So if you look at
see the CT?
yeah, so we will see that hemivertebra is just a part of the scoliosis. Maybe this is the reason which led to scoliosis, but we can see the curve in the lumbar spine as well as in the thoracic spine already. It's already there, and it's balanced. So doing just hemi excision, I think we're not going to balance the curve, and the scoliosis is not much. So the first thing I would have done at this stage was to follow up the patient and see whether the scoliosis is getting worse or not. the best time for hemivertebral excision in my opinion is 3 to 5 years. Once we cross 5 years, we really have to establish that what are we going to achieve by doing the hemi excision. If we see there is still a proximal thoracic curve as well as a lumbar curve in this, not proximal main thoracic curve as well as a lumbar curve in this. So I would have established whether the scoliosis is getting worse, and I would have maybe thought of even growing rod, because just doing hemi excision may not have stopped the progression of scoliosis proximally as well as distally. Second, I personally, if I go for hemi excision at this age, I would have gone 2 levels up and 2 levels below at least. See,
But right now, what is your suggestion? Right now, how to proceed? Now, probably that was the right thing to do.
no, I mean it's not whatever they did was also right. It's just another viewpoint. How I would have done it. Now, in the second stage also, there was already a proximal thoracic curve. So we have tackled the hemivertebra and the distal curve, and the proximal curve is still progressing. So at this stage, the distal curve has been fused, and the proximal is progressive, and the child must be around, I think, 8 or 9 years old. So
Yeah. So
there is still a growth spurt left. So it can get very worse. So what I would do at this stage, maybe I will connect growing rods at the top to this fused mass to control that curve.
right.
Like 2 or 4 screws at the top of the curve. I don't have full length X-rays at the top, and connect them to this distal construct and keep distracting it for another couple of years.
Yeah.
But,
So regarding what you have mentioned, you would have done a two-level fixation. We would also like to have done two-level fixation in that case, but we wanted to prevent excessive fusion in a very early childhood. What you have mentioned, you have to do it very early, but the patient presented at 6 to 7 years to us, and that's what the time was right for us to intervene. Regarding the proximal growth rod, you would have added. I will also agree with that. That I would also, if the child comes to me right now, I will also have added a definitive construct down and a growth rod above. Here you can see there is no need for a growth rod. What you have mentioned, I won't agree with you because she is already riser 2. I think you can see some riser signs there. So this child might be a better case for a definitive fusion, though we will like to study her skeletal maturity in detail.
Sitij, what is your opinion? Would you have put that rod?
Yeah, so the principle of hemivertebra excision, as Hitesh said, that if you are correcting the hemivertebra, you cannot leave end vertebrae behind. So if you see the post-op correction, you have got a hemivertebra excision, but there is still scoliosis below it. So the likelihood of progression is still high because the hemivertebra excision is an acute correction. So if you are going to leave something behind, it is going to progress just because there is some left behind. And one level up, one level below is otherwise a fine construct. But many of these patients need post-op bracing. Some people put hooks as an additional third rod to close down, to do one level up, one level down for a hemivertebra excision. It's a combination of things that have happened. And I agree with Dheeraj, this should be definitive fusion from now at this age.
Okay, Meir, would you agree with Sitij's opinion?
What is the age? I missed the age. Is she 7?
Right. She was 7 when she presented. Right now, she is around 10 plus 10 to 11 years old.
So if she's now 10 to 11 years old, you can take a chance with definitive fusion. But however, she has a lot of growth left. Now, if you go back to the last X-ray, there's a significant amount of kyphosis on the top of the implant. And this kyphosis will not allow a growth rod to be placed now because that's a contraindication for a growth rod. There is a significant amount of kyphosis. There is an implant prominence. That means your rod is now jutting out of your skin. So now you require an acute correction, at least at the adjacent segment. Now, if you want to add 2 more segments of definitive fusion and then on top of that, couple a growth rod or do a modified construct like that, where you want the chest to grow further. So it's like a improvisation in this case. However, if she is 11 plus, then it is a definitive fusion. but she looks like a youngish child with lot of growth left. So
So
you
she
can,
was a syndromic child, and for 6 years she was very small for her age. She was extremely small
so
for her
you
age.
have to really study her biological growth in terms
Yes,
of
so I have already mentioned she was having Turner syndrome like signs.
yeah, so basically you need to study her humerus, her triradiate cartilages, as well as the riser sign
Right.
together. Do not depend only on the riser sign. If she is still pre-menarchal, she
Right.
has at least 4 years of growth left. And you have to be very wary of this because you will end up really constricting her chest if you add a definitive fusion. So
Right.
if you can just correct that acute kyphosis on the top, reduce the
So this
implant.
is what I have done, sir. This is what I have done
No,
after the
no,
failure.
the last X-ray, the last X-ray, the
This one.
last one.
Okay,
Yeah,
the last one. You want to see the
the
last one?
last one where we have a
Yeah,
problem
this
now.
one.
Yeah,
Right. Right.
so she is bending very significantly now.
Yes.
So if you take a traction X-ray, you will probably see whether the proximal curve is stretching out or not. So
Right.
you will have to first see whether that curve rod, because most of these curves will become stiff if you have added an implant. So you really have to now balance whether you can still put a growth rod end to end because you have an implant already which is fused.
Right.
So you can use the lower construct and attach a growth rod on the top. You understand?
Right.
So you
Right.
can use the
Right.
screws below and attach a growth rod on the top and still stretch out the chest.
Right.
So you
Right.
Dheeraj, is this the final X-ray now?
Yes, I just asked this patient recently, few weeks back. He has sent me the X-ray on WhatsApp. I also was surprised to see this, sir.
Okay.
no, it is.
Sitij, at this
Can I
one,
add?
Sitij,
Yeah.
sorry, Mihir, what is your suggestion at this point of time? Now, this is the present
No,
situation.
I think, Dheeraj, yesterday also we meant about underestimating the curves. This was not a simple hemivertebra. It was a congenital scoliosis with a hemivertebra. The hemivertebra was just a part of the deformity.
Right.
So it is not very surprising that now we have a progressive curve because that curve was anyway going to progress.
You had
Yes.
a
Yes.
you had a curve after this correction. So if you see a X-ray before this, you had a curve already above this correction at the start of
Yes. Yes. I have
the
noticed that curve.
so
We wanted
so
to do a two-stage procedure for that
yeah.
curve, but
So
because of
at
lockdown,
this point in time, there is growth rod system is just going to add to the multiple surgeries she's going to have. The definitive fusion is not going to. I mean, she's going to have a short trunk. That's fine, but if you're doing growth rod for pulmonary function, it's not needed at this age.
Okay.
What is your plan, Dheeraj, at present?
So yeah, so I'm planning for a definitive fusion. I can see some skeletal maturity, but we'll try to reassess whether she is skeletally mature. If she is having triradiate fused or near to fusion and riser 0 to 1 plus. Suppose she is riser 2, then we'll go for a definitive fusion. If she is 0 to 1 riser, we'll go for a growth rod. That's our plan right now.
Okay. Can you,
So
thank you. Can you,
just to
yeah.
tell, risers are very inaccurate.
Right,
You don't
right. But
depend
there
on
is no other
risers.
way
There are
we
a lot
can.
of you'll have to consider more things.
I think we can.
What else you consider, Sitij, besides rises, for the benefit
So,
of the
but
viewers?
overall, you'll have to see the bone age. So calculate the bone age, see the triradiate cartilage, see the hand.
Mhm.
But I think at 11, 12 years, this patient is, you said we don't know because she's syndromic. She's not, menarche
Right,
has not been achieved.
right, right,
Correct?
right.
Okay. Thank you,
Also,
Dheeraj.
one thing I want to add, there is a lower disc which suggests you of some adding on. Can Sitish or Mihir sir can comment on this?
Yeah, so that is what I wanted to
Yeah,
add to.
yeah,
We are just looking at the curve above. The pelvis is also tilting below.
yeah.
So the pelvis is now getting decompensated. So if you really want to add a definitive fusion, you have to fix her down to the pelvis. That means you are giving her a very stiff spine at the
Right,
beginning of her age. And that is
right,
going to be a difficult proposition for her. So you
right.
have to be very careful in planning this, and you have to study her biological age and see
Right.
what would be the best for her.
Okay, okay.
Thank you.
So
Thank
yeah,
you. Let's
so
move on to the next
yes,
case
yes.
by Dheeraj
So
again. In the
yes.
meantime, is there any question on the YouTube? Sitish? Okay. We move on to the next case.
Yes, thank you, sir. So these are the two cases experiencing neurological worsening and how we have tackled this to reverse that. So this he was an 18 years old male with a progressive deformity with a paraparesis and near non-functional power. Was just managing to stand for this pick with a on by a holding hand. There is a hyperkyphosis as well as hyperlordosis in the lumbar spine. He was spastic. So you can see here there was a kyphosis as well as scoliosis of 80 degree. There is a big hemivertebra there at the thoracolumbar junction, and so it's a rigid deformity. Yeah. So these are the X-rays for a 18 years old boy with paraparesis. These are the CTs of this patient. Yeah. So obviously we have to do a hemivertebrectomy, and I have planned for a hemivertebrectomy in this patient. We were not able to get any signals since prior only, since he was already having a neurological deficit. The plan in this patient was, apart from hemivertebrectomy, since he was paraplegic and we have studied his MRI, we have excised the pedicle on the concave sides, both sides of the concave side, which was flush to the cord. And we have excised that prior. Then we have gone for a hemivertebrectomy later on in the same stage, and then we have corrected this deformity. So the problem in this patient, what happened? So post-op, his neurology became zero. So on left side, he improved what from prior slightly, and on right side he become completely zero with areflexia and atonia. And though there was no handling as such on the right side, uh, and which was very surprising for us why this happened. Anybody wants to comment right now why this happened?
No, I think is it that it's a brown sequard where you have a motor on one side and the sensations on the other side? See, hemicord syndromes are known after a hemivertebra excision. We know that whether it's handling or whether it's stretching or whether it is an ischemic insult, you may have one leg getting affected more than the other, or the other leg may remain normal. But
Right.
that's just the way these deformities are. So there's nothing surprising about it.
Okay, okay.
First,
Kshitij, you want to comment on this? You want to add something?
So let's ask Hitesh. Hitesh,
Okay,
first
okay.
of all, there is a question in my mind. Why is she having neurological deficit? Because this much of deformity cannot cause neurological deficit.
Yeah, you can see there is a 80 plus deformity with a it's an angular deformity in both the planes. Hence, it should be it's very common for such patient to present as a deformity. You can see the cord is flush to both the pedicles on the concave side.
I mean, unless there is a cord anomaly,
No. So in acute such deformity, it's relatively common to have almost in 1/4 of this patient they present with a neurological worsening.
Dr. Mihir.
Yeah, so I think to answer Hitesh's question, Hitesh, because they could not do a neuro monitoring. Now, if the implant position is correct, there can be all theoretical causes of having a neurological deficit. Now, we have to take it from Dheeraj that the execution of the surgery was with minimal cord handling. So, if we take it from there, then the causes of neurological deficit are known. They're all textbook causes.
I'm saying preoperative. Preoperative. I mean, I cannot see the MRI, but I haven't seen many with 80-degree deformity presenting with neurological deficit. I'm taking preoperatively. Preoperatively, 80-degree will not cause neurological deficit.
If this is distributed around 5, 6 plus the segment, that is a different thing. If it's along one single level, this patient we have been seeing continuously in our practice to present almost 1/4 of this patient present with some paraparesis, and we have a
So
series for such kind of.
why the neuro monitoring was a problem?
So he was already having paraparesis, hence we were not able to detect anything.
You didn't get baseline. Did you attend?
Yes.
You didn't
Yes,
get
we
baseline.
attempted. We didn't get anything.
Was it
No,
up?
Dheeraj, to further on Kshitij's comment, see, SSCP can still be monitored. It's a question of how you test for your MEPs. You may not be
Okay.
able to get all the muscle groups, but the muscle
Okay.
groups that are functional, that is 4 plus, you can get with an higher stimulus.
Okay.
So if
Okay.
you are able to get a baseline, you can monitor these specific muscle groups during the surgery. So I
Okay.
think this particular case was to be monitored because
Right.
4 and 3 is a monitorable sort of a situation.
So
Right.
I'll just summarize before we move to the next case. So
Uh,
I
can
don't
I
think this
show-
is surprising at all. If a patient has a pre-existing neurological deficit, the chances that the patient develops a neurological deficit after a VCR surgery are high.
Right.
You know,
So
you
so what?
already are starting with a sick cord. The
Yeah.
question of handling becomes whether you handle the cord or not. That's a different thing. But the fact that you have corrected this deformity by doing an osteotomy, that itself is a risk to the spinal cord, especially if it's
Right.
a sick spinal cord.
Yes.
On top
So
of it, you are not able to monitor it. So
right.
something like this is in the high risk category of having neurological deficits after PVCR.
Right.
Now,
Kshitij,
what
should I
next,
complete the
Dheeraj?
case? Yes. So what we are very confident that cord handling wasn't there, and on the right side specifically because we have not touched the cord out there itself. So and there was a reflexia which was bothering us, with complete sensory loss which was bothering us. So this is very likely to recover from this stage. Hence, what we were suspecting a bigger cage as a cause. So while pushing or tapping this cage, I thought that the right side has slightly distracted more, and hence I planned for a revision surgery next day only with a smaller cage. You can see I put a smaller cage, compressed both the sides, and let the cord get relaxed on that side. So somehow we were successful. On the very same day, patient's toe movement was started, and within 2 weeks he improved. His reflexes improved very next day to hyperreflexia, which is also a good sign from a reflexia. So this is what we suspected, and we were lucky to get the neurological back on the very next day. So this is the post-op neurology. At 3 months, he was back to the previous stage with slight improvement, and this is the correction at the end. And yeah, so his post-op completely recovered at 12 months follow-up.
Okay.
Any comments?
I mean, my comment to it is that the patient potentially could have recovered without your intervention also.
Oh, that was
you can't be sure. It's a matter of you will not know because you have done an intervention. Because
we can
hard
debate
to
on
tell
that.
now.
We can debate on that.
I would disagree with Kshitij because
yes.
I think in
please.
whatever cases over the last 10 years we have done, whenever we have a neuromonitoring loss during surgery, and if we are not able to find any screw malpositioning or anything compressing the cord, every time I have compressed it, the signals have returned. I mean, of course, after the blood pressure control and everything. So I think stretching of the cord is one of the, in my experience, is one of the most common causes of neurological deficit. And I think he did the right thing by going in and relaxing the cord, because the moment it's returned on the very next day, they would have returned even without doing anything. But I think the chances were he definitely.
Yeah, I mean the deficit prompts you to do something, but the question is always that partial deficits, one-sided deficits can still recover. So it's not a complete spinal cord injury.
Kshitij, I will disagree with this. A reflexia and complete loss of a even a deep sensation is not a good sign, especially on one side, if other side is relatively healthy. And you have been hearing, Dr. Lanke, that no form of stretching of the spinal column in any form of osteotomy is to be accepted.
Okay.
No, I agree with you that it prompts you to do something, but I'm just saying that things can still improve without doing anything.
Yeah, but we have had let's go to concluding remarks.
Okay.
Dheeraj, can I have a concluding remarks from Mihir? One line.
Mihir? Yeah, so I think I partly agree with Kshitij, partly with Hitesh. See, I think when you have a stretch on table, you expect a symmetrical loss on both sides. Okay, that is what the neuromonitoring shows. This is an asymmetrical loss, which probably means that there is an insult to the hemichord. Now, it is that in a day when you have just changed the implant, the areflexes lower motor neuron type of lesion recovers and becomes functional in a matter of few days. I don't think we have seen such a thing. So it is not the implant. There was something else happening. And probably this cord was in a shock state and it was coming out of a shock state. So that's the more rational explanation for this.
Kshitij, your concluding remarks before Dheeraj will conclude.
I think, I agree with Mihir. It's very difficult to retrospectively say something. but the surgeon is the best judge. So if Dheeraj feels that during surgery he has put a large cage and if the dura was tense or something, then it's right for him to go down and shorten it. It depends on the surgeon, what he feels, what has happened. And only thing I would want to say is that with osteotomy surgeries, you should not say that I have not handled the cord. Osteotomy by itself is handling the cord.
Sitish, Dr.
Means
Mukhi is
handling the
asking,
cord is different. You are breaking the column and then straightening it. So that itself is a risk to a sick cord.
Sitish,
Things can
Dr.
go wrong.
Mukhi is asking any investigation like Mars MRI would help.
Yeah, you would do that before your surgery. So, because you want to identify the reason for the deficit, right? So imaging is required before you take the patient up for surgery.
Yeah, we already
Okay.
have done the imaging. Just
Okay.
He must have done it, because what if there was a screw inside? You would take the patient for surgery and then not know about it.
Right.
Okay. Dheeraj, can you give your concluding remarks about,
Yes,
for the take home message? Yeah.
Yes, just a take-home message is to check the dura tension on the both sides. Areflexia or atonia is a worse sign, but a unilateral neurological deficit with a dura intact is a good sign. A cage insertion with bone graft after correction shouldn't be hammered, and also we have to check on the concave side whether there is a relative stretching at that time. Control shortening on both convex, but more on convex side shortening has to be done, but also on the convex side we have to shorten the column, and no lengthening of the spinal column in congenital deformity, especially on the concave side, is acceptable.
Dheeraj,
Yeah.
Dheeraj,
Yeah. Yes, sir.
Yes, sir. Please.
can you conclude
Dr.
by saying
Babulkar, sir. Yeah.
that the neurological deficit deteriorated after first surgery was mainly because of the distraction,
Yes.
and it was necessary to go intervene and take out the implant and relax the tension so
Yes,
that
sir.
there is enough time for the recovery.
Right.
Okay.
Whether without surgery patient would have improved or not, it's a matter of chance, but it is necessary that you should intervene immediately once you see that there is a deterioration of the neurodeficit.
Right.
Am I right?
Yes, sir. You're absolutely right, sir.
Thank you. Thank you, sir. Thank you, Dheeraj, for an excellent cases
Thank you,
on
sir.
scoliosis. Let us move on to the next case, Dr. Swapnil Keni, who is our Honorary Secretary of Bombay Orthopedic Society, and is an Honorary Associate Professor in the JJ Hospital, to present his case.
Thank you very much, Professor Mohanty, Dr. Pawar, for giving me this opportunity. I'm presenting a case of a modified 4-in-1 cross union in an operated case of congenital tibial pseudarthrosis in a 6-year-old child. This had failed essentially. So this is the patient, a 6-year-old operated elsewhere for a congenital tibiofibular pseudarthrosis. As we all can see that this is a suboptimal fixation. The distal part of the implant is jutting out of the distal fragment. It is not holding the distal fragment. The fibula nail is all right, but this is not really an optimal surgery. So if you look at the Paley's classification for congenital tibial pseudarthrosis, this patient falls in 4A, which is a tibiofibular pseudarthrosis with a non-overriding fibula. And if you look at the overall success rates of conventional surgeries, which came out in 2019 in the Journal of Children's Orthopedics, rodding has almost 40% success rate. Elizarov has 57%. Elizarov plus rodding has 58% success rate. Free vascularized fibula has 58% success rate, and combined procedures have 50.7% success rate. And though the primary union rate is almost quite good, almost to the range of 70%, but the refracture rate is significant for conventional surgeries in congenital tibial pseudarthrosis. And hence, we decided to do what is described by In-Ho Choi in Journal of Pediatric Orthopedics 2011, which is a 4-in-1 osteosynthesis for the atrophic type congenital tibial pseudarthrosis. Now, this involves excision of the atrophic bone fragments in the hematoma, intramedullary rodding after end-to-end docking of the fragments, application of an autogenous cortical and cancellous bone grafts in the form of a barrel to form a fusion mass and a cross union between the tibia and the fibula, and application of an Elizarov external fixator along with a second stage lengthening. The plan as described by Choi, this is exactly what was done. So in the first stage, we exposed the pseudarthrosis, removed the hematoma, we debrided the ends, we decancellated the surfaces of the tibia and the fibula. And here you have to actually understand that we expose the tibia and the fibula from the same incision. We reflect the neurovascular bundle laterally. So we expose the tibia, the fibula, and the intervening interosseous membrane. We go anterior and posterior so that we have the entire mass in front of us and we can access this mass. We also start by harvesting iliac crest bone graft from the inner table of the iliac crest, which is the graft which has got multiple threads. We take an anterior cortical bone graft from the opposite side tibia, which we will use for this case. We also take copious amounts of cancellous bone graft, and even in a small child, as Paley has described, if you split open the iliac apophysis and slowly try and remove graft, especially from the supraacetabular area, you can get copious amounts of cancellous bone graft in such patients. The third stage is insertion of a reamed fasciadual intramedullary nail. I will not go into the details of that because this is a little beyond the scope of this case, but an FD nail, which is an expanding rod, is what is used. The fourth step is to try and construct a barrel of fusion mass between the tibia and the fibula by inserting graft in the interosseous space, as well as circumferentially around the tibia and the fibula, and then try and put an onlay graft anteriorly and posteriorly, so everything forms a barrel kind of a graft. So you place this iliac crest graft, you pass it beneath the tibia and fibula and put it posterior. Your threads are on the lateral side. You're going to tie this eventually. Once this is done, you tend to shingle the tibia and the fibula, not only at the fracture side, but slightly above and slightly below. You place the graft, copious amounts of graft in the interosseous space on the medial side of the tibia, over the fibula. Once that is done, you take your two cortical struts which you have harvested from the contralateral tibia, place it on this construct, and then you use your vicryl thread to tie all this construct. This is after the nail has been passed. So this is the kind of barrel effect which this gives. So this is a complete fusion mass or a cross union between the tibia and the fibula. Then you tend to use an Elizarov external fixator to stabilize this. Now in this case, we decided not to lengthen this at this stage because we wanted union. We had planned for a secondary lengthening. So this is the immediate post-op. This you can see the anterior and the posterior cortical grafts which are kind of sandwiching the bone, the tibia. This is a 3-month follow-up. As you can see, there is copious amount of bone graft and it is starting to consolidate. You can see that the rod in the fibula was just left there so that the fibula is held in place. This is also a part of the surgery. This is the 6 months follow-up where you can see further consolidation. Eventually, at 12 months, you can see a very good-looking fusion mass. Following this, the Elizarov fixator was removed. I do agree that there is a little bit of valgus, but that you tend to do later. You first need to get a good fusion. But there was a little bit of infection at the proximal end of this proximal tibia. So we had to go ahead and remove the rod. And we had planned a second stage Elizarov reconstruction with removal of the fibular implant and then doing a lengthening. But unfortunately, the lockdown came in. So this is the X-ray that the patient sent to me eventually. There is a good fusion mass. There are some issues. There is a tethering of the distal fibula causing a valgus deformity, which we wish to correct eventually with multiple surgeries. And there is about 4 centimeters of limb length discrepancy, which we will treat later. So the patient is presently in the native place, as I said. Now, if you look at the literature review of the 4-in-1 osteosynthesis, the refracture rate is almost 0, and there is a 100% survival rate in the Choi series, the series which we have followed. And if you look at the series from Drawer-Palais, it's a modified cross-union technique. This was published in 2018 in the Journal of Children's Orthopedics. He uses preoperative zoledronic acid, which we did not, in the dose of 0.02 milligram per kg. He does rodding. He uses bone mineral proteins, BMPs, cancellous bone grafts, osteoperiosteal grafts, which he takes from the inner cortex, inner table of the iliac crest around the fracture site. And he stabilizes either with an external fixator after rodding, or nowadays he uses a plate. And this modified cross-union technique, he is presented his results of 5.3 years. There is a 100% cross-union with 0 fracture rates. So to conclude my case, this is a 4-in-1 cross-union technique with a very high rate of union, unlike all the previously described methods for CPT. the two large series which have been there in CPT for this particular technique has a union rate of almost 100%, and this is probably an answer and a foolproof method to prevent the problems of refracture in congenital tibial pseudarthrosis. Thank you.
Thank you, Swapnil. Just for the benefit of the delegates, so what is the role of Elijah then? Just make the patient mobilize and mobilize the knee. Suppose I would have put a cast instead of Elijah. You are not doing any lengthening, correct?
Yes. So mobilize the knee. That is the basic idea. And second is it can also give you an opportunity to kind of have a second hold on the tibia, just in case there is a problem with your primary implant. Yeah.
Then you invite the whole set of problems of Elijah, like pin tract, infection, loosening, all these things, isn't it?
Yes, but actually, if you look at the Paley's series, then his union is almost in about 5 months. And our union took a little more time. Probably it was a little more cautious. But in what is said, at least for a revision case, is that you have to throw the entire kitchen sink at these. You just cannot put a rod, and if the rod loosens, then you are really into problems. I mean, you cannot then decide to put a laser of later.
And
So
Dr. Mukhi is asking why not a locking plate?
Yeah, so locking plate is something which Paley has described in the recent past. And since this was one of our first cases, we decided that we would be better served with an laser. Plus, the child was very, very young. So the subcutaneous, the plate would have been subcutaneous. That is why we decided that a laser would be better.
Okay. Dr. Sangeet is asking, can you just again tell what is this 4-in-1 about it?
Yeah, so basically, so excise atrophic bones, intramedullary rodding, cancellous bone grafts, and Alizero fixating. So this is basically what the 4-in-1 technique essentially means. But what he actually meant is, Choi meant is that he would use cortical graft, he would use cancellous graft, he would use rodding, and he would use an Alizero fixating.
Dr. Mangal, Dr. Pawar, yeah, please.
Swapnil, after putting so much of cancellous graft, cortical graft, and intramedullary rod, how was difficult to do the closure of the soft tissue? I think it is more difficult to close.
Yeah, so sir, what we did was we have reflected a reasonably good flap, and there has been a significant undermining just above the level of the periosteum, deep fascia. So after doing that, it's not really that difficult, because everything is lying flush onto the anterior and the posterior surface of the tibia. And these are very thin anterior cortical and posterior cortical grafts. So not really difficult to close.
And second thing is, there is a varus deformity at the ankle. How could we mobilize the patient?
Yeah, that is a valgus deformity, and that is very well known after Ilizarov at times. But the reason for this, we couldn't mobilize the ankle early, is essentially because our construct was crossing the ankle. If you see this, and it has been described that you actually need to cross the ankle to get this sort of a fixation. So unless you remove this, you cannot mobilize. So there are problems. I do agree that there are problems, but usually when it is a young child, these problems do get sorted out or can be sorted out later when you tend to start physiotherapy.
Dr. Mangal Pariyar, your opinion, please.
Yeah. No, you were asking about the Ilizarov. The Ilizarov mainly gives you the rotational control, because the rod gives you axial stability, and the Ilizarov corrects, or rather prevents, rotational instability. You made a statement that why add the Ilizarov, then you add the problems of pin side infection, etc. Yeah. Similarly, why do a TKR? Because that adds the problem of infected knee, fusion, etc. So
no, I just added when there is some other alternative can be possible.
No, I'm pulling your leg. But the reasoning is that you require, as he said, you have to throw everything that you have at this, so that you get this to heal. And there is nothing like the Ilizarov in a child, because these are very short segments usually. So nothing like the Ilizarov with fine wires, which will allow you rotational control.
Okay. So Alaric, just have Alaric's comments. And
no, I think that's a great result, and this is the standard of care for CPT nowadays. Just to clarify what Swapnil said, 4-in-1 actually means bringing the two ends of the tibia fibula proximally and the distal ends of the tibia and fibula together. So basically, you're bringing 4 bones together and making them into one fusion mass. So that's why it's called a 4-in-1 procedure. And the valgus that you see, Swapnil, is sometimes present in CPT. We have seen that happen in many of our cases. And I think that's very easily dealt with by putting a growth modulation or an 8-plate on the proximal tibia, and sometimes a screw in the distal tibia if you have ankle valgus as well. So it's important to get the alignment right, because we know that if you don't get the right alignment, the chance of refracture is extremely high. So I would advise you at this point to go ahead with the growth once the child comes back from the lockdown, to put a growth modulation on the proximal tibia and a screw across the distal tibia to get that alignment absolutely perfect. And of course, then put the child in a clamshell orthosis, which is extremely important again to prevent a refracture. I notice you've also removed the nail from the tibia, and that's again a bit unsafe, because we know that stabilization is absolutely important, because you see a good fusion mass right now, but there's nothing to say that it won't break down in a few months or years' time. So once you've got the union, it's important to have a rod in all the time and even exchange the rod at regular intervals once it falls short, and to also use the clamshell orthosis from the outside to give more stability. Thank you.
Thanks.
Mandari,
Mandari, your last comments. Yes.
So excellent result, Swapnil. I'll just like to have a few points. One is that, we published this a couple of years back with Dr. Alric and Sandeep Vaidya. So we have now gone over to just fixing the tibia. And we have now, last few cases, we have started putting plate. So a small plate, just a 2.7 or a 3.5 plate, which you just slide from right below the proximal physis to just above the distal physis, will hold the bone much better. What happens in these cases, just like in your case where there is very poor hold or even of the FD rod at the distal and the proximal physis. So the rod doesn't behave like a telescoping rod per se, because the physis itself is quite poor and there is deformities at the ends, as has been in this case. So I suggest that in the next few cases, probably you can try just fixing the tibia itself and not do a transcalcaneal kind of fixation, and try to put a hybrid fixation with a plate along with the nail. So,
Swapnil, what is your plan now to correct this valgus deformity, and your concluding remarks before we proceed on to the next case?
Yeah, so basically, I plan to do exactly what Dr. Alaric said, is we probably need to have a rod in here again. The reason why we removed it, because there was some amount of infection there. So we didn't really want the entire tibia to get osteomyelitic, so we removed this rod. But we shall try and put another, maybe an elastic nail, and then have some sort of a support for the tibia if it is possible at this moment. And at the same time, use an 8-plate proximally as well as distally, remove the fibular rod and try and correct this deformity. This child is still young, he's about 8 years old. And eventually at some stage, we would have to lengthen this to get to equalize the limb lengths.
Okay, thank you. Thank you, Swapnil. That was an excellent outcome. Let us move on to the next, pediatric case by Dr. Prasanna. In the meantime, Dr. Mukhi is asking, lateral infra malleolus is causing valgus ankle.
Yeah, so we will remove the nail, which was the rod which was passed, and we'll just wait and watch how things go.
Okay, thanks. Dr. Prasanna, please go ahead. We are unable to hear you.
Please unmute yourself.
Am I audible now, sir?
Yeah.
Yes.
Good morning, everybody. The 14-year-old female patient came with complaints of right hip pain and limp since 1 year, and there was no history of trauma or any infection. On examination, there was no local rise of temperature, tenderness was present, there was no swelling, a range of motion was full but painful, there was no limb length discrepancy, there was no deformity. Inflammatory markers and other blood investigations like alkaline phosphatase, parathyroid hormone, calcium and phosphorus were normal. An X-ray showed well-defined expansional medullary lesion with ground glass appearance with a thick sclerotic border in the right neck femur inferior aspect. Did the same X-ray in zoom view showing expansile medullary lesion with a thick sclerotic border. Is a T1 MRI coronal image shows a low intensity signal suggestive of fibrous tissue. This is the T2 MRI coronal image showing a higher intensity signal. This stage means what can be done.
Yeah, Alaric, your comments?
Yeah, so this is a fairly large lesion in the neck and has a potential for developing a pathological fracture. Of course, I think biopsy would be warranted, though it looks obviously benign, but we have learned not to take these things lightly. So a biopsy followed by a fixation would be what's required. You may choose to bone graft. If this turns out to be a benign lesion, you may bone graft it, but we have seen in most of these benign lesions, the bone graft tends to resorb. So I think a primary fixation with some sort of a screw plate implant would be the ideal fixation once you have proven the diagnosis with a biopsy. Thank you.
Would you do a CT guided biopsy or a needle biopsy? Okay. Alaric?
Well, the problem with CT guided at times we find is, the sample is not representative. They seem to use a very fine needle. So unless you're doing it yourself in the CT scan room with a thick bore J needle to get an adequate biopsy, I think then might be safer to do it yourself in the OR. This is a fairly accessible site in the medial part of the neck of the femur, so it can be easily accessed through a medial approach. So either one, as long as you can get good tissue biopsy.
Would you treat during the same time, because it looks like a benign lesion? So why not treat in the same sitting, or would you take a biopsy and do a second sitting again surgery? Take the
Sure, you definitely could, but Manish Agarwal has scared us so many times in so many BOS meetings, showing us all these benign-looking lesions which then turn out to be malignant. So I think to be on the safe side, medico-legally, there's no harm in doing a biopsy first, being absolutely safe, and then doing a definitive procedure the second time.
Yeah. So Swapnil, what is your take on this? Would you do same sitting, or would you do biopsy first, then go ahead to the second stage?
I would certainly do a biopsy first, and depending on the biopsy result, I will take it further.
Okay. Okay. Please go ahead. Yeah. What did you do?
Sir, actually, we didn't do biopsy initially. We thought it was benign. So management options will be conservative, or we have to fix internally along with grafting, or only internal fixation. We are managed with the curettage of the lesion with fibular grafting and prophylactic fixation using 2 cc screw, and the curated material, which was grayish white, was sent for histopathological examination. This is the immediate postoperative X-ray showing the fibular grafting and the prophylactic fixation using 2 cc screws, the apine lateral view. The histopathological examination confirmed the diagnosis of fibrodysplasia. It showed metaplastic oven bone in hypocellular fibroblastic stroma. And this the X-ray at 1.5 years follow shows the well incorporated fibular graft. Is the functional outcome of the patient. Patient can sit and squat without any pain or discomfort. Patient is able to walk without any limp.
Dr. Prasanna, would you put that fibula graft little longer so that, by crossing that lesion into the inferior quadrant of the head?
Show the X-ray, Prasanna.
Yes.
So the final is, yeah.
Yeah.
So, I would have put the fibula graft little longer until the subchondral, part of the inferior quadrant of the head. Rather than, that would have been better, so that it will support the calcar as well as the prevent the collapse of the head.
Okay.
Yeah.
And only the pathological region, sir.
Yeah. That's fine. That's fine.
Okay.
So, Dr. Mangal, would you have done a single stage surgery, or again you would have done a biopsy?
As Alaric pointed out, I think doing a biopsy is today a better idea, because I'm always worried about what things look like and what they ultimately turn out to be. So yes, it does add to the surgery, adds a little to the cost and all that. But I think overall, it's the safer way to go.
Yeah, biopsy is always preferable, but sometimes, you may see if you have taken inadequate material, then they just give a report that material is inadequate, inconclusive,
Yes.
like that. Then that becomes a problem. So Dr. Mukhi's opinion is that core biopsy first, PFN is my choice. Would you do PFN in this case? Any one of Dr. Mangal, Dr. Swapnil?
So this is, I think, a prophylactic fixation before a fracture has already occurred.
Okay.
And he has kind of given a very strong construct here. So as long as this consolidates and he is not kept weight bearing, I think this should heal very well. Why would you put a PFN and try and put such a large implant and then put a screw there?
Yeah.
When you can do with these screws.
Okay. So the result has been outstanding. So success cannot be challenged. Thank you, Dr. Prasanna, for this presentation. Anything regarding fibrous dysplasia, post-operative, any other thing you do?
Sir,
or any other
I
treatment?
mentioned one article.
Yeah.
So according to Nishida and et al., they have managed 8 patients of fibrous dysplasia with a fibular graft and a dynamic hip screw. Means they have concluded that autogenous fibular cortical shunt grafting with internal fixation that achieves good post-operative function and provides an early return to work for patients with fibrous dysplasia, the mild and prolonged symptoms.
But is it a pediatric patient or an adult patient?
Sir, they have taken, actually they have taken this age range from 20 to 35 years. Yes.
Okay.
It's not exactly pediatric.
Okay. Thank you.
Thank you, sir.
Thank you. Let's move ahead with the next case by Dr. Harshit. In the meantime, okay.
Mukhi sir is asking some question. Yes, Mukhi sir.
Because in my experience, I've seen that fibrous dysplasia failing with DHS. That's why I do PFN. And second thing, I always do PTH study. Because I have found out 3 cases of fibrous dysplasia on histopathology. What they were having parathyroid hormone raised. One was in tibia and 2 were in femur. So there's no harm in doing a PTH assay.
Yeah, point
Yes,
well
sir,
taken.
we rolled out.
Yeah.
Yes.
We should do a serum PTH probably because they are cystic lesions, and even one cystic lesion, one should do a parathormone study.
Please unmute Dr. Harshit. He's muted. Yeah, Harshit, you're unmuted.
Good morning, respected faculty. Presenting a case of a 14-year-old boy who
Please play your
presented
PPT. Play your PPT.
Good morning, everyone. Presenting a case of a 14-year-old boy who presented with complaint of right hip pain for 1 month. Pain was sudden onset and progressed to a state where the boy was not able to bear any weight on affected side. There was no history of any recent trauma. On examination, tenderness was present. Active as well as spatial range of motion was severely restricted and painful. There was a shortening of about 1 centimeter, and patient had high-pitched voice and was overweight. We investigated him with X-ray with pelvis with both hips, and this was his X-ray. We made a provisional diagnosis of slipped capital femoral epiphysis, but we got a CT scan done to see the relation of the head and neck and the position of the head. We found something suspicious going on at the junction of the head and neck, and also his differential was 70 and ESR was raised to 54. Hence, we got his MRI done. On MRI, the right side hip was completely filled with pus, and there was intermuscular as well as intramuscular abscesses all around the right side of the hip. The head was completely necrosed and turned into a sequestrum, as you can see on the MRI. So as next line of management, we did a biopsy through Smith-Peterson approach. Intraoperatively, there was purulent pus and head was completely necrosed. A thorough debridement was done and samples were sent for culture sensitivity and histopathological examination. On histopath examination, the results were acute non-specific granulomatous inflammation, and culture sensitivity MRS is sensitive to clindamycin, linezolide, tetracycline, and gentamicin. The patient was managed with injectable linezolide and clindamycin for 3 weeks and oral linezolide and clindamycin for yet another 3 weeks. He was put on skin traction with intermittent physiotherapy. At 6 weeks, patient was completely relieved of pain. His differential was 70, ESR came down to 15, and CRP was negative. So as next line of management, we planned the patient for right-sided pelvic support osteotomy, and after 6 weeks, distal femur valgus corrective osteotomy or LRS fixation for axis correction. This was post-op day 1 after pelvic support osteotomy. After 6 weeks of the first procedure, we did distal femur LRS for valgus correction. This was post-op day 1 after LRS. This was post-op 3 months after LRS. This was post-op 10 months after the removal of the LRS. We were able to correct the axis. This is clinical photo at 10 months, just before removal of the LRS. Patient was full weight bearing, walking with residual shortening of 2 centimeter. This video has been taken just after the removal of LRS, hence we gave him walker. Patient was walking, at present patient is walking without any support. So the message from this case was a 14-year-old child who presented with a clinical picture of slip capital femoral epiphysis eventually turned out to be a pathological fracture secondary to an infective cause. There was no history of fever. There was no any history that suggested us towards a underlying cause being a infection. In the review of literature, I could just find one such example in which the patient initially had a septic arthritis of the hip, and after 2 weeks, he got a slipped capital femoral epiphysis in an adolescent boy. That was it, sir.
Mandar, what do you think the cause of this lesion pathology? Then we can come to management. We'll discuss about management. Mandar, are you there?
Earlier X-ray.
Yeah, first X-ray just so the first X-ray.
Pre-op.
Yeah. Pre-op X-ray.
Yeah, this was a pre-op X-ray.
I think Mandar is not there.
Okay, then Swapnil, what do you think the cause of this lesion?
Since this is my case, basically this patient was shown to me presenting like an SCFE, but not very classically.
Okay.
So that is why we had done a CT, but we decided to do an MRI because we were suspecting some sort of an infection. If you look at the proximal femoral neck and the head, there is some sort of, kind of a necrosis kind of a picture, which is again not very classical of a SCFE. And again, there was no open injury. So this is probably an inside out sort of an infection, which is mimicking a slip capital femoral epiphysis.
Okay. Dr. Farooq, what is your opinion about this case? Dr. Farooq is there?
Yes, hi, I'm here.
Hi. Yeah.
Hi. Yeah, I mean, I agree with Swapnil. I think the initial X-ray picture also looks a little bit suspicious to begin with that little osteolysis around the neck. So I think I would have also investigated along the same lines as what Swapnil did.
Okay. And regarding the, management, Mangalu, do you agree about putting LRS and, doing the lengthening after doing the osteotomy?
Yeah, I mean, this is the equivalent of a Tom Smith arthritis.
Yeah.
There is no real hip. So Elizarov pelvic support or a 2-in-1 has been shown to have probably the best results. One may sort of argue about, what is the simplest way to do it. But ultimately, you have to get valgus proximally and varus distally to equalize, to normalize the axis. So I wouldn't really fight with this. I would probably do it all with a fixator, but this is equally valid way of doing it.
What is the knee range of movements in this patient now?
So at present, it is up to 90 only. There's decreased range of motion. Because patient also went home. We advised him physiotherapy. He could not come back because of lockdown. And when he came,
after doing so much of lengthening and all this thing, I think 90 degrees is a fairly good range of movements for this particular patient. And how much shortening is there now?
So 2 centimeters, sir.
Okay, you're just giving a shoe raise now, no other
Yes, sir.
procedure.
Sure. At present, he is walking without any walker, sir.
Okay,
I couldn't get the latest video, but I contacted him. We gave the walker because we took this video just after LRS removal.
Okay. Dr. Mukhi, your comments about the case? Anything else you would have done?
Just show the first X-ray. You see the acetabulum is involved and the joint space is not there, X-ray. And you see a lighting lesion in the acetabulum. You see the space is not there at all. And there's a lighting lesion as compared to the opposite side. And you see that this CRP is not done, or at least you have not mentioned. So you have no right to touch him without a biopsy. And you did the biopsy and the decompression. But you went in very fast with the plate. When you suspect pyogenic infection, you have to wait. 6 weeks is a very short period. And to put a metal in 6 weeks of infection, I'm a little afraid. What's your opinion, sir?
No, it was clear. No, so we did an anterior, when we decided to take a biopsy, we actually got out the head, we kind of did a complete debridement.
But still, the plates will get infected in 6 weeks.
Oh, now that is a matter of debate. It really, you can go by the clinical judgment. So clinical as well as, I think we have done the investigations in the post-op period, wherein we went in only when we were certain that the infection was quiescent, clinically and radiologically. So CRP was negative when we decided to put the plate in.
Okay, and it was MRSA.
Yeah.
What was it? MRSA, yeah. Oh.
MRSA.
Okay.
It was MRSA.
Okay, and you treated with the first antibiotic for a couple of weeks.
Yes, sir, both clindamycin and linezolid, both for 6 weeks, 3 weeks injectable and 3 weeks oral.
Okay.
And we had put him on skin traction with intermittent physiotherapy also during that 6 weeks.
Okay.
CRP and ESR was normal, sir, before operating for pelvic support osteotomy.
Okay. So did you do a hip aspiration also? No.
No, sir, we directly went, hip aspiration was not done before the second surgery.
Okay.
We relied on the symptomatic relief as well as blood investigation.
Yeah, that is more important. That clinical assessment, clinical judgment is more important than your investigations.
So when patient came, he was in severe pain, but after 6 weeks, he was completely relieved of pain.
Okay.
And
that was also favorable.
You have to stop the antibiotics for 15 days and put in a needle, do a culture, and whenever you are doing a biopsy, you must ask for even tuberculosis. Because in our country, I have seen that though you may get MRSA and all that, still they turn out to be tubercle.
Done a histopathology. There is acute non-specific granulomatous inflammation. That's what he's saying.
So this was also sent for gene expert and TB culture. So that were negative.
Yeah, thank you.
I did not mention because that was negative.
Yeah, thank you. Thank you.
I think Dr. Alaric has a point.
Yeah, Alaric, your final comments, please, before we move on to next case.
It's quite well managed. There's no doubt about the fact that this is a post-infective slip of the epiphysis. I would like to point you to one paper that we published in Journal of Pediatric Orthopedics in 2000, where we showed 2 cases of slipped epiphysis. In fact, the whole epiphysis was lying loose within the joint. And this was again post-infection. One was in the hip and one was in the knee. And in this case, we actually fixed the epiphysis back onto the femoral neck, pinned it, and we showed a 12-year follow-up that the head had completely recovered. Of course, these were both neonates, so I'm not suggesting that in this case. I'm just putting the point across that if you see this in a young child, it happens at times, very rare condition where you can have a septic arthritis with a complete displacement of the epiphysis. Don't try and throw the epiphysis out if you're unsure, put it back, pin it, because sometimes in young children, the recovery can be extremely good. Here in your case, I can see that the head was really necrotic and destroyed. You had no other option, but I'm just putting it out there for the younger members, because you might come across such a situation where you see an epiphysis loose when you open up the joint for an arthrotomy, and the temptation is to throw that epiphysis out. But we have shown that, there's always a chance that you can give it. You can, if it does necrose and go avascular, you can remove it anytime and do exactly what you have done right now. But I think that's a great result. And as Mangal pointed out there are two ways of doing this. You can do this with a fixator, which is our preference of doing the ilies of hip reconstruction, because in one go, you can get proximal valgus, and distal you can get varus and lengthening as well. But there's no contraindication to what you have done. It's perfectly fine to do it in 2 stages. The only thing is that while we are doing the varus osteotomy down, I would have also done some lengthening, because we have lost length in the femur. So at the same point, to get some lengthening, and especially even a little bit of over lengthening, because this child still has a little bit more to grow. Otherwise, I think that's a great result. Thank you.
Thank you. Thank you, Alaric. Let's move on to the next case of adult SCFE by Dr. Samir Panchal. In the meantime, just whatever, Dr. Mukhi says, and all biopsies must be cultured, or cultures must be biopsied.
And lengthening at that stage would have helped to healing faster at the hip.
Yeah.
The regenerate helps in controlling the infection and healing of that infection also.
Okay, that's what Alaric suggested also. You would have done little lengthening during, so that, you gain the limb length. Yes, Samir, your case, please. Can you unmute yourself? Yeah. Can you make a slideshow?
Samir, go ahead.
One more question can I ask? Is that okay? Sorry.
Yeah, we are not able to hear Samir.
Why 2 plates were used there?
We are not able to hear Dr. Samir. You have unmuted, but there is some audio issue.
Samir, do you want to sort out your problem and we take the next case?
Yeah. Let us move on to Dr. Yogesh's case.
Hello. Sir, am I audible now? Hello?
Yeah. Okay, please go ahead. Yeah. Please make it a slideshow and please go ahead. Yeah, continue with the presentation otherwise. Yeah.
Samir, there is, I think, some issue.
Mohanty sir, we can move on a second case.
Yeah, please.
Solve the problem.
Yeah, we move on to Dr. Yogesh Rathod's case next.
Yogesh, are you there?
Yogesh, can you please share your screen? Samir, in the meantime, you can sort out your issues with Dr. Siti Chaudhary.
Am I audible, sir?
Yeah.
Yeah, please share your screen. Please share your screen.
Samir, you unshare your screen.
Samir's screen is unshared. Yogesh has to share his screen.
Good morning, sir. Hello, am I audible?
We are not seeing your screen.
But we are not seeing your screen. Please share your screen.
Go at the bottom. Green button. Can you see the green arrow down?
No, sir.
Dr. Mukhi is asking why 2 plates. Can you have why 2 plates you have put, Dr. Harshit? Proximally in Sanjastotomy place.
Yeah. I think I'll answer that.
Yeah.
Because this is basically a DCP, and in one of our cases of our series, we've had an issue with an implant failure. So we decided to kind of have a more stable construct, because this is an area where there is a significant amount of muscle forces acting. And when you give valgus, even with some amount of shortening, there is still, some chance of this kind of failing. So that is why we wanted to be doubly sure. Though it is not described, but we decided to kind of strengthen the construct.
And how much angulation do you give for a sand gastrectomy?
So
how
as
much
much
wedge
as
you take out?
it is as much valgus as you can. There is a limit to which you can do in a plate. This is, I think, almost 30 degrees of a wedge. So it's like an exchange wedge. You remove about 20 degrees and then you take a 10-degree wedge and push it on the medial side to kind of gain a little more valgus. But I would agree that it is quite difficult to give valgus with a plate, significant valgus with a plate.
So you pre-bend the plate and
yes, the plate is pre-bent to about 30
plan
degrees.
and pre-bend the plate and then
Yes,
put the plate.
yes,
Okay.
yes.
And
Lokesh,
why not rock?
share
Hello?
your screen in the meantime.
Sir, is my screen visible, sir? I've shared it.
No. Or else
We'll go to the third one. I'll speak to him. So
yeah, Dr. Nadir sir, are you ready with the presentation? Yes, Samir has. No, yeah, Samir, you can go ahead. Go ahead with your presentation. Go to slideshow. Yeah. Yeah, click there. You didn't click there. Click there. Yeah.
Sir, am I audible now?
Yeah. Okay. Now I can go ahead. Fine.
Sir, am I audible? Hello.
Yeah.
Okay. A very good morning to all the faculty. Sir, I'll be presenting a case of adult onset slip capital femoral epiphysis. My patient, 20-year-old male, he presented with complaint of pain in left hip and difficulty in walking, following an history of trivial falls since 2 weeks. There were no history of trauma to any other part. Sir, on examination, he was unable to bear weight. Their rotations were painful and there was an obligatory external rotation. Apart from this finding, sir, there were few typical features which came to our notice. Was the short stature of the patient. As per his age, there were coarse facial features, delayed developmental milestones. The patient also gave a history of school dropout because of bullying in view of short stature. With this clinical background, we have advised the concerned X-rays. So these are the X-rays, sir. Looking at the X-rays, sir, we suspected the diagnosis of an adult onset slip capital femoral epiphysis. But looking on the clinical features of the patient, we wanted to evaluate the patient on the endocrinological profile. So in view of that, we have advised serum T3, T4, TSH, and it was confirmed that the patient was an undiagnosed case of primary hypothyroidism. So concerning with the treatment was started in the form of levothyroxine to the patient. With this clinical background, we planned the patient for an operative intervention in the form of close reduction and internal fixation with CC screws on traction table. We were able to achieve an acceptable reduction as soon as positioning the patient on the traction table. We just made the limb, we slightly internally rotated the limb to neutral position, and with minimal traction, we were able to achieve the reduction, sir. And fixation was stabilized with the help of two 6.5 mm partially threaded CC screws. This is the immediate post-op X-ray, sir. This is a 1-year follow-up of the patient. And in this, sir, we can finally see the epiphysis has been fused, sir.
Yeah. Why do you tell it's an adult SCFE?
Sir, the patient is a 20-year-old male. When he presented to us, looking at the X-rays.
That means the epiphysis was not fused when he presented?
No, sir. Epiphysis was not fused, sir. So it was not, the bone age and the chronological age was not correlating, sir. But as we suspected and the diagnosis of hypothyroidism was confirmed, so there was delayed in the fusion of epiphysis, sir.
Okay. And have you done any, Dr. Mukhi is asking, have you done any, endocrine workup?
Sir, yes, sir. Sir, I have shown this report, sir. It was clearly showing the patient was a case of primary hypothyroidism.
Any gonad studies?
No, sir, no gonadal study because we confirmed thyroidism. So we have started treatment on that. basis only, sir.
Is there any incidence that hypothyroidism leads to delayed closure of the epiphysis?
Sir, yes, sir. It leads to.
Okay.
Sir, I'll quote the
Dr.
article, sir.
Yeah, Dr. Bavulkar, please. Sir, your comments.
No, I think it was chronic slip. When it became finally upwards, then he presented. Otherwise, he has a typical picture of endocrinal pathology. And
Okay, sir.
all studies were in favor.
Okay. And Dr. Ram Prabhu, please.
So basically, this is an endocrine problem. I have not seen any adult SCFE yet, but I think there is a possibility since your epiphysis is open and the treatment which has been given, I think, is properly given. And we, of course, need to do some more endocrine study to confirm or whether there is any other problems, endocrinal problem besides hypothyroidism.
Okay.
Can I just interject here?
Yeah, Farooq, yeah.
Yeah, hi. So yeah, basically we did do all the endocrine studies. The patient was referred to the pediatric endocrine unit at Nair Hospital, and they did do growth hormone studies as well as pituitary studies, and everything else was ruled out. And it was only primary hypothyroidism that was diagnosis. Yeah.
Okay. There's
Basically,
a question
I cannot
from...
make out how these CC screws have been put because they are halfway. Maybe this X-ray has been taken later on, but what is the entry point of the CC screws?
Sir, the trajectory of the screw is basically from anterior to posterior. So, sir, in case of a mild slip where there is a very minimal relative retroversion of the femur neck, the trajectory of the screw is to aim the center of the femoral epiphysis. So they have to project from anterior to posterior, sir. But in this case, sir, as we see from the preoperative X-ray, the slip was very severe. So it has been described, sir, the entry point is at the base of the neck. But in case of severe slip, we have to take an entry from the superior aspect of the neck. So we had to go a little bit anterior, sir.
But you could reduce the slip on the table?
Yes, sir. It was just a positional reduction.
Okay.
The limb was
So
in external rotation. We did an internal rotation maneuver to make the limb neutral. And with minimal traction, we were able to get this, sir.
Dr. Alaric has a question, has a point.
Yeah, Dr. Alaric, please. Can you unmute him?
Yeah, thank you. So I think you've got a good result, but I think a couple of points I would raise.
Yes,
the first, of course, it's quite well known that if you have certain syndromes, if you have, for example, Down syndrome is known to have, again, delayed puberty. Again, hypothyroidism is known to have a delayed closure of the physis.
Yes,
So
sir.
in all respects, this is almost like an adolescent slip, which is presented at a later age, just because of the fact that prologic age and the bone age don't match.
Yes, sir.
What I would caution against here is a close reduction, even if it's incidental. The very fact of applying traction, I don't think is recommended in today's day and age. When we say incidental, it means really that you put the child on the table and it reduces by itself. If you have to impose any form of reduction, it's not recommended at all. You got away with this time without AVN, but in the future, I would suggest that go by an anterior approach. Do what Klaus Pasha described with the help of a finger manipulation. You can reduce the head over the neck because it's an unstable slip. But any form of close traction and reduction would not be recommended for a slip. Once I've reduced the head, as I can see in this case, I'm not able to understand why you need to put a trajectory which is going from anterior to posterior, because it's a fairly well-reduced epiphysis now, whether you do it by reduction or you do it by closed methods. It's always recommended to use the longest screw possible. And once you've got the reduction, to put it the standard way from the lateral approach, so that you get the longest possible screw, which has the best mechanical advantage. This one has a windshield wiper effect. The shorter the screw that you have, and
okay, sir,
there's a good chance it might fail. Of course, you've got a good result, so there's no debating that. But for the future, these are the 2 points that I would suggest.
Okay, sir.
Alric, can I interject again?
Yes.
Yeah.
Yeah, hi. So basically, we did not do any reduction maneuver. It was basically just literally positioning the patient on the traction table. there was no traction applied as such, so we did not do any. And the reason for the trajectory of the screw was because the reduction wasn't a full reduction. There was still a residual, probably a mild SCFE still remaining after the positioning.
So suppose you are not able to reduce Alaric, then what would you do? You will do osteotomies and all rather than doing
No,
the
this is
manual.
an unstable slip, so there's no reason why it would not reduce. It's a wide open physis. And as I mentioned, I never attempt any sort of closed reduction in this case. As Farooq rightly said, if it so you position the child on the table and take an X-ray, and if you find it's reduced just by the positioning, that's all that you will accept. If it doesn't, and if it is not complete, I would not hesitate to open by an anterior approach. Klaus Pasha described this really well, and that's what we use for all unstable slips nowadays, where you use a finger or a K-wire to reduce it in a very guarded manner while actually watching it under close vision. And once you've reduced it, then go ahead and pin it in the standard manner.
Okay.
Yes, sir.
Dr. Swapnil is of opinion there is a coxa vara, coxa breva, and a large femoral head. So may get arthritic after 45 to 50, then he can come to me. So no problem.
Question
But
to
right now patient is
Farooq.
painless. Yeah.
Farooq,
Yes, sir.
is there a risk of AVN after reduction in
There
this
is
case?
definitely a risk of AVN with an unstable slip. Unfortunately for us, he did not get that. But there is definitely a risk of AVN. And therefore, as Alric pointed out, we do not do any reduction maneuver as such. We just, it's a positional reduction that we have tried to achieve.
Yeah.
Okay. Let's move on to the next case by Dr. Nadir Shah. I'm sorry, Dr. Yogesh Rathod, hypertrophic ossification.
Yogesh has
Thank
just
you.
logged out and will log in back. So
Okay, we can take up Dr. Nadir Shah's case then next. Dr. Nadir, you are ready with the case?
Unmute Dr. Nadir, please. Please unmute Dr. Nadir.
Yeah, I have done already. Dr. Nadir,
Am I audible?
Yeah.
Yes. Please share your screen.
Am I visible?
Yeah, you are visible and audible. Yeah.
So very good morning to all of you. This is Dr. Nadir Shah. I'm presenting a case on infected total knee replacement and management of it. So here we have a case of a 73-year-old female operated case of a total knee replacement done elsewhere. Patient was walking and asymptomatic post 2 months of the surgery. After 2 months, she developed pain and swelling in the left knee. She was also complaining of difficulty in walking. Joint aspiration revealed MRSA sensitive to linezolid, ticoplanin, and clindamycin. The investigation showed increased positive CRP 176.25, low hemoglobin less than 9 grams, and increased counts up to 17,200. Patient was then taken up for surgery. Tibial component was removed. Femoral component was retained. Cement spacer was done, and patient were advised for revision TTR after completing the antibiotic course. Patient then visited JJ Hospital for the first time. Patient had come with pain and inability to walk, discharging sinus, and severe stiffness. These were the blood investigations later. The hemoglobin had reached to 10, WBC counts were 17,000, positive CRP, and ESR was raised up to 52. This was a pre-op picture with a retained femoral component and a tibial spacer, AP and lateral views. Patient was then again taken for surgery. Loose femoral component was removed. A thorough debridement was done. Vancomycin, tobramycin, and infiltrated cement spacer was placed. Intraoperative samples were sent for culture sensitivity, which had no organisms. HPE was non-specific inflammation. culture negative infection accounts for 7 to 11% of all the cases. This was the X-ray after the femoral component was removed. Once the infection was resolved, a revision total knee replacement was planned for the patient. Lab investigation just before the surgery revealed ESR had come down to 6, CRP was negative, and counts had come down to 9,000. Revision TKR was done. Synthetic calcium pellet were used with erythromycin and colistin. Link hinge knee was used as collaterals were damaged and were not salvageable. This is the immediate revision TKR X-ray showing good alignment and good coverage of the bone. This is a follow-up X-ray after 6 months. And this is another follow-up X-ray after a period of a year. So here we have a very interesting paper in Journal of Arthroplasty. Definition of periprosthetic hip and knee infection, the evidence-based and validated criteria. The paper says that 2 positive culture of presence of a sinus tract is considered as a major criteria and diagnostic of periprosthetic joint infections. The calculated weight and elevated serum CRP more than 1 milligram, D-dimer more than 860, and erythroid cell ESR more than 30 were graded at 2, 2, and 1 points respectively. These are the other major and minor criteria which help in deciding whether the it's a periprosthetic joint infection or no. The criteria are with 2 positive culture of the same organism and sinus tract with evidence of communication with the joint or visualization of the prosthesis. Minor criteria include serum and synovial fluid, in which the minor criteria include elevated D-dimer or CRP levels, elevated ESR levels, which are scored at 2 and 1. Synovial fluid are graded with elevated WBC count, positive alpha deficit, elevated PMN, and elevated CRP. All these scores are 3, 3, 2, and 1. The probable conclusion for decision for infection is the grading more than 6. Similarly, inconclusive pre-op or dry tap in case of a dry tap, a preoperative score, positive histology, positive purulence, and single positive culture are the intraoperative diagnosis. Again, the decisive factor becomes with a grading more than 6. 4 to 5 become inconclusive, and less than 3 will be determined as non-infective. Thank you.
Thank you, Nadir, for an excellently managed case. The only thing is that the criteria 2018 criteria, what you have shown, is actually difficult to follow in our situation, because it's based on all these laboratory parameters like alpha defensin, D-dimer, and leukocyte esterase, all these things. So which is difficult. Either those things are not available or these are very expensive for our patients. So that's why unless we follow only the major criteria, the minor criteria is difficult to follow in our setup for all the orthopedic surgeons in general. So still we follow the criteria of 2011 by Javad Parviji, which was modified in 2013. Now, the thing is that, my question is, in the first stage, when the spacer was put, why femoral component was left behind? Why it was not, taken out and spacer was put at the first place itself?
During the first surgery, the patient presented to us with this. So I think that time the femoral component was not loose. This is what I feel. This was done somewhere else. So
okay.
When we went in, we found the femoral component was loose.
That's fine. But, whenever in an infected knee, for the benefit of the delegates, the message is that you have to take out all the hardware. Even if femoral component is not loose, once it is diagnosed infection, you have to take out the femoral component and put a cement spacer. All this cement also has to be taken out, otherwise there are chances of recurrence of infection. Metal and cement. Even if you leave, take out all the metals, but leave a flake of cement there are chances of reinfection. So femoral component, the message is should not be left behind even if it is well fixed, either of the components. Then number 2, at the first place also ESR was not done. So ESR CRP together increases the diagnostic accuracy. either ESR and CRP, it is important. CRP is more sensitive than ESR, but both ESR, high ESR and CRP, that the sensitiveness is more compared to either ESR or CRP. And number 3, there was a MRSA which was isolated, and as Dr. Mukhi also pointed out, that every tissue should be sent for histopathology and also culture for tuberculosis in our country, as well as fungal infection if the patient has got any evidence of immunosuppression, like if the patient is chronically diabetic or rheumatoid or any immunosuppression, if you're suspecting, please send it for fungal culture as well. So these are the things one must keep in mind while doing a infected total knee replacement. Yeah, Dr. Sangeet, your opinion, please. Dr. Sangeet Gawale.
Sangeet, sir.
Yeah, I didn't hear it because I am busy with giving direction for the next presentation.
Okay, okay, no problem. Yeah, Dr. Mukhi, yes, your comments, please.
I want to know to use a stemmed spacer, because the medullary canal is also infected.
Yeah.
And why not use a mobile stemmed spacer?
Yeah.
What is your opinion?
Nadir, yeah. Nadir, what is your opinion about stemmed spacer?
We can use it. Actually, I feel it's more of a surgeon's choice.
Yeah, no, the importance is that, intramedullary infection. Many times, we put the spacer in the joint and the medullary canal gets blocked, and it's an intramedullary infection which leads to recurrence again. So nowadays we are putting intramedullary, calcium sulfate pellets, this stimulant, mixed with antibiotics into the medullary canal itself. That takes care of the infection. And we prepare the dowels of cement, cigars of cement using 5 cc or 2 cc syringes, join them, put a K-wire inside and push it inside the medullary canal and give traction, then put the cement in the joint space. So that takes care of intramedullary infection, and then during second stage it can easily be pulled out. And number 2, it also provides more stability to your spacer. So 2 things, it takes an intramedullary infection and also provides stability to the spacer so that patient can walk without having minimal pain.
For the purpose of the delegates, I would like to know that when to add antibiotic to the cement.
When to add antibiotic?
To the cement, in a cement spacer. Do you add first only or you add later on?
Yeah, while mixing the cement, Dr. Mukhi's question is that while mixing the cement with the antibiotics, when you add that antibiotic powder to the cement, either from the beginning you mix with the powder, or after the cement, you mix the liquid, then when the cement polymerizes, that time you add the
No, we mix it in the start only.
Start. No, it's advised to mix it after the bubbling of the cement, because the elution of the antibiotic is very good when you mix it after the bubbling.
So, yeah.
That is the concept in the AOS. Do you agree with me, Monty?
Yeah. Yeah, there are 2 schools of thought. If the antibiotic anyway, if it is thermostable antibiotic, like aminoglycosides, like streptomycin and all, and your cephalosporins, vancomycin, it's
Hello.
I think we have lost, Dr. Mohanty has lost connection. So maybe.
Hello?
I think Dr. Mohanty's video is frozen.
Yeah. Pawar sir, please continue the discussion.
Mukhi sir.
Yes, sir.
Already few of them comes already pre-mixed antibiotics. In these cases, what is your opinion?
I don't use that.
So you preferably do the mixing of the antibiotic after?
after the bubbling.
Okay.
The elution is much faster.
What is the advantage of that?
When the elution is there and complete, if you put it first, then the elution is very slow and it is not that prolonged. Just that is the literature in the AOS. There is a very good paper and very good demonstration when to mix the antibiotic in that cement.
Okay. Thank you, sir.
Right.
Thank you very much.
Dr. Mohanty has lost his internet, so I would request Dr. Pawar and Dr. Gawale to kindly hold on to the proceedings till sir comes back.
Yeah, yeah. We will move on the next case. Dr. Yogesh is ready.
Thank
Dr.
you.
Yogesh. If Dr. Yogesh is not ready, then we can move on to Dr. Sandeep.
Yogesh, you can share your screen and try it. If not, if it's not working again, then let the next person go. Yeah, Yogesh has started. Where is your presentation?
Any toxic effect of vancomycin, systemic toxic effect noted with that much concentration of vancomycin.
Play your presentation.
Go to slideshow.
Slideshow, please.
Unmute yourself.
Close this window, please. Close this, cross this. Don't create account, cross it. Close this window, the one which is telling you to sign in the office. Dr. Yogesh. Dr. Yogesh.
He has not
unmute yourself. We are not able to talk to you. I think Yogesh is struggling, so we can go ahead with the next one.
Kshitij, can you ask him to send a presentation to you so that you can play?
Yeah, I'll do that. So I think the next person can go ahead.
Sandeep.
Dr. Mohanty has joined back.
Sandeep, start steering.
Sandeep.
Yes, sir. Good morning, all the respected teachers and
share your screen.
Yes, sir.
I think in the last, when there is the last question being asked, please unshare your screen and let the next speaker share the screen and let the Q&A continue for that case so that we'll have less lag between the two cases.
Sandeep, go ahead.
I think Dr. Mohanty is back.
My case is about neck femur and shaft femur non-union in a case of below knee amputation.
Please play your presentation.
Yeah, I'm trying to play, but I'm unable to.
Click on the screen or use the arrow buttons at the corner.
Yeah. 49-year-old male without any comorbidities. He had a road traffic accident 7 months back, and he had a femur shaft fracture which was closed and ipsilateral near total below knee amputation. He was managed with a distal femur closed nailing and below knee amputation was done. The case was being managed elsewhere. These are the pre-op and post-op X-rays at the time of primary surgery. Then, after a few months, he started walking with prosthesis and walker, but he had pain in the hip and thigh while walking. So, for that, he presented to us after 7 months of the primary surgery with pain in the right hip, thigh, and inability to bear weight on the right side. So, these were the X-rays and clinical picture at the time of the presentation. The radiographs, they are showing non-union at the distal femur side maybe probably because the DFN was not locked in the proximal area. And also, to our surprise, there was a neck femur fracture, and that's why he had pain in the hip joint. And this is the clinical picture. So now we have a case of neck femur non-union, which is almost 7 months old, with DFN in situ and non-union at the femur shaft. So what should be the management protocol? I would like experts to talk.
Dr. Junjunwala, please. Sir, your opinion. Are you able to hear us? Okay. Dr. Babulkar, please.
Yeah.
Hello. Hello.
This is
Hello.
Yeah.
I
Junjunwala,
will remove this nail and put a recon nail which can fix up the neck as well as the shaft and do the bone grafting at the shaft level.
Can you show the X-ray down below in the knee?
Yeah. There is non-union.
Yeah. Can you show the knee?
Knee
How long
X-ray
the nail?
actually it's not here, sir.
How long the nail is extending? We are not able to know.
Actually, it's there here.
Yeah,
In this X-ray, we can see.
Okay. And there is no infection, correct?
No infection, sir. No any scar sinus.
Okay. Dr. Babulkar, sir, please. Yeah.
Subhranshu,
Sir.
this is a typical non-union of shaft of the femur with a combination injury of fracture neck femur. I think the fracture neck femur was not diagnosed primarily. It was there. So what I would do is exchange this nail to a little shorter nail, do a good fixation of neck femur by DHS on the plate, and do bone grafting at the fracture site of femur. The combination injury treated by DHS with a side plate and division of nail to a shorter nail and bone grafting.
Okay. So there is a process of union. The fracture looks to be, but not completely united, but callus is there all around.
You should not take any chance.
Yeah,
I think it's
correct.
necessary that you should put a bone graft. After exchanging the nail to a little short, nail should end at the lesser trochanter, where you can do a DHS and side plate fixation. With a 1 hole or 2 hole plate, it is sufficient to fix the neck femur.
Would you do a abduction osteotomy as Dr. Mukhi is suggesting?
At this stage, I would not do it.
So you think the fracture would be...
May I? Monty, sir?
Yeah.
May I?
Please.
No, I would put in a shorter retrograde nail only and put a DHS which will pass through the nail. You know, the school bypassing the nail, missing the nail technique. And do an abduction osteotomy, which is a must.
Are you still using the intramedullary supracondylar nails? There are some issues about it, in the literature that it was going to be out of the market.
Supracondylar nails. Why?
Yeah, you will put a supracondylar nail, correct?
Yeah. Retrograde.
Okay.
Yeah. Shorter nail, long DHS plate. And that graft which you remove at the abduction osteotomy site, put it there and plate that also site. You will not have any problem.
Mukhi, sir.
Yeah. Dr. Mutha has got something to tell. Dr. Satish Mutha.
Mohanty, can I intervene?
Yeah, please, sir. Please, sir. Dr. Babulkar. Okay. Dr. Mangal, your opinion, please. Dr. Mangal Pariyar, you are there?
Hello.
Yeah, we are able to hear you, sir. Please go ahead. Yeah, please go ahead.
Doing a valgus osteotomy, you are creating more instability for the fracture neck femur. I think short fixation by DHS and a plate and bone grafting would be ideal situation.
Considering the duration of the fracture, that since
Yeah.
it is so, abduction osteotomy you probably would convert it to a compressive force, and the chances of union are more rather than doing only DHS. You have to augment with something, isn't it,
No,
sir?
no. I
And
fully
then
agree.
Powell's angle. Powell's angle is more than 70. So you have to do
You
an
can
abduction
still
osteotomy.
You can still reduce the fracture. You might require open reduction. Do it proper fixation.
Okay, okay. Dr. Sangeet Gawale, your opinion, please.
At this stage, if you see the amount of callus with the loose implant inside the medullary canal, which is unusual, the amount of callus probably suggests there may be an infection which we have to rule out. One. Second, is we don't know the status of
Can
human.
you please mute everybody, Sitish, and allow me to control? There are a lot of disturbance.
Yeah.
Yeah.
Considering the hip fracture being an old one, so we don't know the status of the vascularity of the humeral head, of the femoral head. So two things is, one is to rule out infection, and second, we should know something about the vascularity of the femoral head. So relevant investigations would be advocated, which should be advocated before you consider any final treatment.
Correct. Yeah.
Mohanty sir, you have to consider, I am fully agree with
Dr.
Sangeet
Sandeep.
sir. It is almost 7 months old. So you have to
Dr.
check for
Sandeep.
whether there is a AVN or not. And that will conclude very important in the management part.
Can we proceed with the case?
Yeah, there is again some problem with Mohanty's audio. We can proceed. Sandeep, go ahead.
Swapnil,
yes.
I think you have muted all. That's why he is unable to present.
No.
You unmute Sandeep.
I can't see him. Wait a second. I think the host has unmuted him.
Yes, sir.
Yeah, go ahead.
Yes, sir. So we did all the infection markers. They were the negative, and we did MRI also. And MRI showed changes of the AVN in the femoral head. Hence, we decided to go ahead with the THR with distally interlocked modular femoral reconstruction prosthesis. As the distal fitting stem would not be ideal in this case, as the fracture is well below the isthmus, and so the distal fitting stem will not have a hold in the stem. So we decided to go with the modular femoral reconstruction prosthesis, which is distally interlocked. But on table, after putting the longest femoral stem trial, the proximal locking bolt was coming very close to the non-union site. So we were not able to bypass the non-union site at least 10 to 12 centimeters. So we decided to put a primary stem and plating of the non-union. Procedure was completed satisfactorily with good hip stability, and adequate compression at the non-union site was achieved. The removed callus was used as a bone graft at non-union site. So these were the immediate post-op X-rays. The hip center is restored well. The stem is fitting well, and we have achieved good compression at the non-union site. We have filled the callus also there to enhance biology of the non-union site. And we started the knee and hip ROM exercises after drain removal and dressing. We kept him non-weight bearing for 6 weeks, but we started him on knee and hip ROM exercises. Then after 6 weeks, we started him on partial weight bearing with the help of his prosthesis and walker. And after 3 months, total weight bearing was increased gradually, and gait training with the help of prosthesis started. So So at 6 months, these are the follow-up radiographs. They are showing good union at the non-union site, and also the good uptake of the acetabular component, and femoral stem is also very well placed in this skill set. So any comment from the panelists?
Satish Mutha? Mutha sir, can you comment? Your comment, please. Unmute, unmute.
Yeah.
Yes, sir.
Dr. Sandeep, why did in the first place you thought of putting a long stem? I mean, because a long stem survival of distal locking stems is definitely not as good as a primary. So what you had to do by default on table could have been a primary plan, right? To do a THR or whatever and fix the fracture.
We thought that we could come out with a single implant and it will be better. Intramedullary implant is always better for a non-union thing. That's why we were thinking of a distally locked long stem.
How old was the patient?
For 51-year-olds.
But why did you change the plan intraoperatively? Your plan was something else and you executed something different.
Yes, sir, because of that the longest stem which was available on table, it had two locking bolts, and the proximal locking bolt, it was coming very close or at the fracture non-union site, and that's why we had to change the plan.
The longest stem would be, I think, 340 or something. So that
Yes,
would
sir. In India, 310 is available, but that day on table we had only 280, the longest stem available, 28 centimeter. That was the problem.
Dr. Mohanty, are you there? Dr.
Yes.
Mohanty?
Yes, yes.
Yeah.
Yeah. Now, this
Yeah,
is
yeah.
the same limb is amputated.
Yes, sir.
So, what is the effect of an amputated limb or a prosthesis on the longevity of the ipsilateral hip? You have any reference or any information on that?
Yes, sir.
The question is to Dr. Mohanty.
Yeah, yeah.
Okay.
Just show your literature. Yeah, I would not, if alternatives are available, I would not go ahead doing a hip replacement in an amputee because, stability is more important in this case. So I would do some kind of, abduction osteotomy and fixation rather than going ahead with a hip replacement. But if the hip is arthritic or there is avascular necrosis of the head, then you could have gone ahead with a total hip replacement because that will be painful. So unless there is pain, it's better to go ahead with a fixation method rather than doing a hip replacement in an amputee. But the literature shows there are hip replacement in as he is showing, and there are many also literature even in KEM we have done 2 cases of hip replacement in an amputee. But those are the hips were painful.
I think Dr. Mohanty is having some problems. So, Sandeep sir,
please.
So this is his functional outcome. His range of motion is good, and he's able to walk with a little bit of limp. Sorry.
Yeah, can you show the literature?
Yes, sir. After this video, shall I?
Yeah.
Yeah, excellent. It's working very nicely. Yeah. Yeah.
Okay.
Any literature?
So this is one case report, primary THR for a femoral neck fracture in a below knee amputee. This is what to learn from this article is femoral neck fracture in below knee amputee should be managed by THR as a primary procedure before the onset of post-traumatic complications, which are much more challenging to treat in case of below knee amputee patients. And there is one more article from Journal of Arthroplasty, total hip arthroplasty in patients with below knee amputations by Moshe Salah et al. And here they have a series of 5 patients in whom they have did total hip replacement in patients with below knee amputations, and they are having good results. So we went ahead with that our plan of the THR, as the patient already had avascular necrosis changes in MRI.
Okay. This is how many years follow-up in these patients?
In this patient, sir, it is almost 9 months follow-up, 9 to 10 months.
Yeah. You have to see for a long-term follow-up of these patients that how they are doing in the amputees.
Yes, sir. Our main worry was whether that fracture will unite or not, but it has united very well, and he is walking comfortably with the help of prosthesis.
Correct. Okay. Thank you. Yes. Thank you, Sandeep. Let's move on to the last case of this session. Adult painful hip dysplasia.
Yogesh's presentation is with me in case you want to allow him to go ahead, but up to you, sir.
Okay, okay. Then we can present Dr. Yogesh presentation. Then we'll have a little, announcement regarding VIRAC. Then we'll move on to the other cases.
So I think Yogesh can unmute and I will move the slides for him.
Yeah. Dr. Yogesh, please go ahead.
Yes, sir. Hello, am I audible, sir?
Yes.
Yes, go ahead, Yogesh.
Good morning to the respected faculty. I'm presenting a case of 36-year-old male presented with right hip pain and restriction of movement since 3 months. He was having a history of right intertrochanteric femur fracture following an RTA, for which patient had undergone DHS plating 1 year back. At the time of trauma, he had no history of head injury and no history of abdominal and chest injury. This was the X-ray at the time of when the patient had incurred trauma. It is evident that there is a right intertrochanteric fracture, for which after getting operated, so he had undergone a DHS plating with an SS file for GT fracture. Patient was discharged on day 5, and day 5 the dressing was, there was no soakage around, it was completely uneventful and was discharged. But after discharge, patient was completely immobile for almost 2 months, despite of asking him for do a partial weight bearing with the help of walker support. After 2 months thereafter, patient started weight bearing with the help of walker support, but had painful there was a pain in the right hip while walking. On examination, there was no swelling. Scar of previous surgery was present, and there is no tenderness when the patient presented. And the range of motion, there was flexion of 70 degree, extension was within normal, and abduction adduction was also within normal limit. There was gross restriction of internal external rotation. We can hardly find any movement. There was rotational restriction. Patient was unable to sit cross-legged. These are the clinical pictures of the patient, which shows that there is a restricted flexion as well as, but adduction abduction is normal, and patient had difficulty in cross-leg sitting and squatting.
Please tell me next when you want to go to the next slide.
So this is the video of the patient where the patient is limping and there is slightly the patient is having antalgic gait. You can play the videos.
No.
The video won't play.
No, the video won't play.
Okay. So there is hardly any restriction. It has been demonstrated.
Yeah, that video is running. Yeah.
There is a restriction of internal external rotation both in full extension as well as in flexion. Next, please, sir.
Next slide, please. Yeah.
Yeah. This was the X-ray when the patient presented to us after 1 year, and there is an excessive ossification seen around the hip joint, which is extra-articular motion, in both AP and lateral view. Next, sir. The metabolic markers, serum calcium, vitamin D3, and alkaline phosphatase was found to be within normal limit, as well as ESR and CRP. Next slide. We had undergone the CT scan of the patient, which is showing the ossification. In the CT scan was done to see the extent of ossification, whether there is involvement, how much it is extended on median and lateral side, as well as to assess for further management. Next slide, sir. These are again the CT cuts of the patient and 3D CT of the patient showing the excessive ossification around the hip joint. Next slide, sir. So what will be the next line of management? As this is a pre-op patient, can you please opine regarding what can be the further management of this patient?
Yeah. So, no, we have excised, 3-4 cases of this ectopic ossification around the hip. The most important thing is that, where is the ossification mass? Here, the beauty is that there is no ossification mass medially. Sometimes the ossification mass may be medially extending from lesser trochanter towards the ischium. So that is the most difficult, part to excise. Otherwise, here the most of the ossification mass is either, posterolateral or little superiorly. So with a routine, posterolateral approach, we can excise the ossification mass and we can see on the table what is the range of movements, and they have got a very good long-term outcome. We have published also one case report in the Journal of Pediatric Orthopedics B, that excision of the ectopic ossification. Here the patient had any head injury or anything?
No, we had asked, there was no history of head injury.
Okay, usually these patients, have a head injury or sometimes, viral encephalitis or some kind of prolonged bedridden conditions where they develop these ectopic ossifications. And excision is the answer, and the ossification should get matured. And usually we do serum alkaline phosphatase, and clinically if you see there is no local rise of temperature or any inflammatory signs, and when you see that alkaline phosphatase has come down to normal, that is the time probably to go ahead with the excision of the ossification mass. Dr. Mukhi is pointing out that they take care of the sciatic nerve. Of course, the sciatic nerve may be, inside the mass sometimes. So you have to look for the neurovascular bundle whenever you are going to do this, that it is not encircling the neurovascular bundle or is it away from there. So that is important. Yeah. Any other comments?
Yeah, and take the care of the vascularity of the head, because you may damage the vascularity of the head while removing the posterior ossification.
Yeah, correct. The most
create AVL.
Can you please mute yourself? There are some
I don't have
disturbance. And because the superior lateral retinacular artery or lateral retinacular artery is most important, which supplies the weight-bearing portion of the head. So especially when you are exercising the superior part of the ectopic ossification mass, one has to take care of the blood supply. But usually these are extra capsular, so there should not be a problem of the blood supply to the head.
I've done 2 or 3 of the 3 of these actually.
Yeah.
And one of the things I would like to sort of point out is, one, of course, you do a CT, try and assess where all the heterotopic ossification is. But the important thing is you don't necessarily need to take out all of the ossification which is present on the X-ray or the CT.
Correct,
in the sense that you assess which is the most likely and attack that one first, and grade your, rather stage your excision based on how much movement you get. So once you have a reasonable range of movement, then you don't necessarily need to go after all of the bone that is seen, because the goal here is to get movement.
Can I?
One more important point to add is that it is difficult to recognize the margin between the ectopic ossification and the normal bone. So it is better that you approach it from the normal bone side, then gradually go excise and see that which part is restricting the movement. And after taking out those flakes of the bone at each movement, you can just go on doing little movements and see that when the maximum movement can be obtained. As Mangal told, that you need not excise the whole mass, but only those part of the mass which is restricting the movements. One thing is difficult to recognize between the normal bone and the ectopic ossification. And second thing is that, whether to go subperiosteal or extraperiosteal, that is again important. Because if you go subperiosteal, there are chances of reossification again. And if you go extraperiosteal, you do a lot of, muscle dissection and on when you are going to take it out. So there, the judgment one has to do. So subperiosteal is a good option so that you don't dissect much of muscles. But if you have exercised good amount and once the patient gains movement, the chances of reossification is though more, but it's not that much alarming. Yes, Sangeet, I think you wanted to.
Now, as what you have described, what is unusual in this case is this is Broker-Willis type 3 or 4, where it extends the complete gluteus medius, right from the ilium to the tip.
Yeah.
And radiological picture and the clinical picture, these are not matching. Considering it is a complete involvement, we still have a good fair movement. Now, second thing is, like when, as all we have discussed, it is matured where the parameters are normal, alkaline phosphatase and ESR are normal. So if we are considering excision, so since it is contained within the medius, so what will be left or what will happen to the medius function if we excise it? And if he insists on removing all to get a better movement, as Mangal has said. Here, the surgery is only to improve the movement. That will compromise the abductor function because the mass is in the medius.
Yeah, but one has to be judgmental that the insertion of the gluteus medius, should not get affected. You just go medial to medius and excise the part which is there superiorly near the greater trochanter, and rest of the part, below the greater trochanter. Medially, you should not go because medially there is still some space. You will have a good adduction and rotation, but need not go medially to excise the whole of the mass. So it is a judgment on the table that, if you get around, say, reasonably 30 degree of abduction or something like that, then you stop there rather than excising everything. And post-operatively, we give a single dose radiation to these patients, 600 centigrade radiation, 600
1
to
dose
700.
of radiation and endomethacin.
Yeah, radiation and indomethacin for about 6
Endomethacin
weeks.
must be given for 3
Six-
weeks.
For about 6 weeks. Yeah, we give 3 weeks to 6 weeks, whatever.
Mohanty, I have a question to you.
Yeah.
During the procedure, is there any role of medius release from the ilium?
In this particular case, I don't think, because it is not extending towards ilium. It is confined more or less on the femoral side.
One suggestion I want to say is that we are using the Mesonex machine. That Mesonex machine only burns the bone and doesn't burn the neurostructures or the vascular structures. And that is the main machine which will help you in safeguarding the superior gluteal nerve, the vessels, and the sciatic nerve. That's my take on this. The
Okay, what is this
surgeon
machine?
used that Mesonex ultrasonic burr.
Okay,
It doesn't
ultrasonic
touch
burr,
the
yeah.
soft tissue. That is
Okay.
my suggestion.
Okay. Okay. Thank you. What is your plan? Can you just show your plan?
We are planning for the same excision,
Okay.
as well as there is a review of literature regarding the same, as sir properly mentioned initially. The combined therapy is considered to be more effective rather than sticking only to the endomethacin in NSAIDs. Endomethacin along with radiotherapy has been found to be superior monotherapy, and the only modality for going for the approaching this case, they have mentioned in review of literature, is an excision if it is completely, when we are assured that it is matured completely.
Okay. Thank you.
Thank you. Thanks a lot.
Thank you for the presentation. Before we go ahead with the next presentation, may I request, we have one important announcement regarding VIRAC 2020 Unlocked. May I request Dr. Satish Mutha, our organizing secretary for VIRAC 2020 Unlocked, and Dr. Mandar Agashe to present regarding announcement regarding our VIRAC. Dr. Satish Mutha, please share your screen. Dr. Yogesh, would you Stop sharing your screen.
It stopped. Pandar can go ahead.
Hello. Oh, it's with me actually, the presenter.
Satish, yeah, you can share your screen. Yeah.
Am I audible, sir?
Yeah, you're audible and visible. Go ahead.
Good morning, friends. This has been a really interesting meeting and very nice cases since morning. As you all must be aware, the Bombay Orthopedic Society will be conducting its annual VIROC scheduled for this year in March 2021. The dates are 19, 20, 21. It's been aptly named as VIROC Unlocked. This time we are going to have a lot of different sessions. We are trying to combine a lot of physical component with virtual activities. So we would be having a lot of different programs like podium presentations, interesting case discussions, present your publication session, and video techniques apart from the regular papers. The abstract submission is now open and the last date has been extended from the end of November to 15th December. We are very happy to share with you that despite initial reservations, we have received very good response and we have received almost 150 papers, including 15 to 20 for the YSF and VSF. And we are hopeful that by the end of 15th, we will be having many more papers. We have also opened the registration from 1st of December. The registration gateway is open on the website along with the payment gateway. We have already had more than 15-20 registrations in the last 4 days, which is quite encouraging for us. And the best thing about this is that we have been able to really negotiate hard with Renaissance. And as you would see on the tariff on the website also, the registration fees are lower than last time. And especially the residential packages are very, very close to the non-residential packages with the difference of only 2,000 rupees approximately. So we wish that you all get registered. You all opt for residential registration. Stay with us, help us and enjoy VIROC Unlocked in March. The registration gateway is open. Hence, we request you to register as quickly as possible. The Renaissance team has been extremely cooperative with us, and we, along with them, have ensured that we will be taking all safety precautions as required in these times, along with adhering to all government regulations. Thank you. Thank you, Dr. Mohanty, sir.
Thank you, Satish and Mandar. That was an excellent package. May I request Dr. Junjunwala to share his screen, please, to present his case. And while he's sharing his screen, let me just tell you that this is the first, physical conference probably after this pandemic that has been declared all over the country. I don't think that any other physical conference has been declared until now. And we had a tremendous response for the abstracts. As Satish told you that till 30th of November we have received 152 abstracts exactly, but still we wanted some more. That's why we extended the date due to demand from various sectors. Because of the pandemic, people could not prepare their abstracts, so we have extended just for 15 days. We are definitely going to close it on 15th of December. We started the registration 1st of December and already we have received some 5-6 registrations until now. And it is heartening to know Dr. B. Sipsankar has registered as the first delegate, with a complete residential package, our president-elect of Indian Orthopedic Association. So please go ahead and register. We'll meet soon with face-to-face and enjoy the VIROC academics. Thank you. Thank you all. Now let us move on with the next session, presentation from the outside institute.
Mohanty,
And
sir.
Dr. Junjunwala is going to present his case. Yes, sir.
Sir, one more case is remaining. Dr. Vipul.
Yeah, we'll go after this session, after the presentation from outside
Okay,
institute.
okay.
Then I will continue with the host institute.
Yeah, sure.
Okay.
Okay. Am I audible? Am I audible?
Yes, sir.
Yeah, you are audible and
Okay, fine.
slides are
Thank
seen.
you.
Yeah. Thank you, sir.
This is a revision hip, and only cup was bad, so cup was changed. Next. Mr. Rajaram Kori, 52 years old male, underwent Austin Moore prosthesis for fracture neck femur in 1994 in Madhya Pradesh, not here. Austin Moore failed in 4 years, and therefore this was converted into cemented total hip replacement in 1998 in Mumbai. That time uncemented hip was not available. This cemented hip got loosened out, this tape got loosened out. You can see the X-ray. There was widening of the shaft of the femur, and the stem was loose. That was in 2003. That is after 5 years of cemented hip replacement. So in 2003, next, revision was done, and a uncemented long stem total hip replacement was done in 2003, and it was uneventful recovery till 2020. That is about 17 years he was walking about on this properly without any pain. Then in 2020, he started getting pain, and slowly he was unable to walk. And that's why he came from his town to Bombay again. And this time, what we thought that the stem is also proper. The cup, possibly there is a little wear of the cup, and therefore we have done revision of the cup. You can see the cup, when it was removed, there was wear of the poly, as well as there was little fracture of the posterolateral part of the cup. Now, this type of cup was not available because of 2003. The cup, they have changed the design of the cup in escallop type of hip. And therefore, if I thought that if I remove the metal cup also, and this was already 58 cup, and therefore I thought that if I remove this, I will be able to put 62 or 64, and it was not available, and therefore I kept the cup, metal cup, in situ, and it was very well fixed up. So it was a multi-hole cup, so I just curated the holes and put cement in that. So what you see here, this is the metal cup, and this is the cement I put, and this is the elite cemented poly I put it inside. And this is the post-operative picture. And after 4 days, the patient could walk with the help of a stick without pain. And it is about 6 months now. He's walking very well without any pain. Thank you.
So how old is this patient?
This is a very simple method where the revision to be done. The metal cup was inside. I put the cement and the cemented poly on that, and it
How
was
old was the
very well.
patient?
78.
How old is the
78?
78, yeah. Okay. Yeah, excellent outcome, sir. Because that is
Yeah.
the very good option in this 78 years old patient where the cup is well fixed. The bottom line is that cup has to be well fixed. If cup is loose, then you cannot do this procedure.
If
And
the better cup is loose,
Dr.
they have to remove it and put a new cup.
Yeah.
But
Yeah.
this cup,
And
metal cup was very well fixed. It was only the poly which was there, and I removed the poly very easily. It was little loosened out because of fracture, and the metal cup was very well fixed.
for the benefit of the viewers, just after taking out the poly, you have to take out the screws. As Dr. Junjunal has shown, she has taken out all these screws. So the cup is well fixed. Then you have to burr the cup. In inner surface of the cup has to be burred and made little rough with some kind of instruments, usually with a burr we do. And then you wash so that cement interlock will be better through the holes as well as on the burring of the cup. Cup becomes little rough, so cement will little better. What was the size of the head, sir, you had used?
28.
28. Okay. So you have to you have changed the head as well?
I had to put a long neck head.
Yeah. So ideally it is to change the head also. And then this is a very good option, revision option with a quick in and quick out. And is there any literature that what is the long-term outcome of this procedure?
No, it is no.
Yeah. The literature shows it takes in a medium term follow-up shows it has got a very good long outcome. About 7 to 10 years follow-up shows it has shown good outcome. Any comments, Sangeet? Your opinion, please.
On the pre-op and the present X-ray, the amount of lysis in the ischium, that is zone 3 of the socket.
Yeah.
Are you happy with that?
No, there is definitely there is some amount of lysis there, but when the cup is well fixed, why unnecessary again take out, and it will require a big reconstruction by putting either a cage or something like that, and it will be difficult to reconstruct. And 78 years old person, I think I would do the same way what sir had done.
Thank you.
Yeah. By the time thank you, sir. That was an excellent case. Let us move over to Dr. Parag Munsi's case. In the meantime, Dr. Harshad, your opinion, please, on this case. Sir, can you stop sharing your screen? Dr. Parag Munsi, can you share your screen? Harshad, your opinion, please. Yeah, your opinion regarding Dr. Junjunala's case.
Oh, sir's case, I think it's an excellent method and a good learning point that rather than revising a well-fixed shell metal, you can use that as a base to implant your cup inside. Only thing you have to have a large shell. If you have a thin cup, then probably the femoral head won't fit in it. So there will be some restrictions. You can't use it unrestricted in every case. The shell has to be large enough to accept a wide cup so that the head will match.
Correct. Harshad had given a very good point that minimum polyethylene thickness should be around 8 millimeter, 8 to 10 millimeter on either side. So if it is a bigger cup, then this option is open. But if you have a smaller cup to start with, say less than 48 to 46 or something like that, then this will be, you have to take out the cup and put a new cup in. Thank you. Thanks, Harshad, for that opinion. Yes, Dr. Parag Munsi, please. We are not able to hear you.
Kshitij, please unmute him.
Parag?
Fracture case. Very mobile fracture case.
Sangeet is unmuted, but somehow we can't hear him.
Here, Parag?
Yeah, I think that's unmuted.
You hear me now?
Yeah.
Yeah, okay, so I'll do the talking. Just let Dr. Mudassir share the screen and I'll keep on saying next because what's happening, the videos are not playing through my computer. So if you let Mudassir forward it as I say next, then we'll be okay. Is that all right with the committee?
Yeah.
Okay, so thank you BOS and thank you JJ Hospital for picking our case. This was a slightly unusual case, A, for two reasons. A lot of us are not using this implant, and B, some of us who are trying to use this implant are not really sure how exactly one should be doing it. So next slide, please. So we have this lady who was 62 years old. She sustained an accidental fall and she injured her right shoulder on 8th of June, 2019. She was insulin-dependent diabetic and she had renal nephritis, so long-term CKD patient with high creatinine on steroids and immunomodulators. However, this was a dominant site and she was still very active, independent and undergoing treatment. Next, please. So this was her primary X-ray when she had the fall in June 2019, which showed a displaced three-part fracture treated elsewhere. Next, please. So she had her CT scans done then. So this is a closer look at the 3D and on the slices as well. And here you can see that the head is displaced and there is significant comminution. Next, please. These are again a close-up from the other side. Next, please. So the question at this stage on behalf of the primary surgeon, what one should be doing? Should we conserve? Should we do a fee loss? Should we pin it or any other modality? I put this because there are some proponents who put in wires and then convert that into an X-fix. Next, please. So the primary surgeon did this procedure where he used the Just Unique implant, which is a French derivative, on 14th of June 2019. And this was the immediate post-op X-ray the next day. Next, please. Now, at 2 weeks, when that lady came for suture removal, the clips were removed and an X-ray was taken which showed this position. So in hindsight, when I spoke to the primary surgeon, I said, were you concerned at this stage? And he said, yes, I wasn't happy, but I thought we will get away and this might unite, so we'll wait. Next slide, please. So at 6 weeks, this lady came back to the primary surgeon and he had taken some specialized views with a view to getting a better idea what's happening inside. But at this stage, she was very, very painful with very poor function and significant night pains. Next, please. So at this stage, she came to me, A, for an opinion only, and then I referred her back to the primary surgeon. So this is what she was. You can see her clinical profile, very poor function. She could just not lift and severely handicapped. Next, please. And then you can see the primary scar, which was taken on the anterior aspect of the shoulder, drifting all the way anterolaterally. Next, please. So then I consulted the surgeon again and I said, look, I'm sending her back to you, but if you're happy, I'll take over her care. So he says, sir, please take over. So then she was referred to me, and on admission under my care, we did first a sonography to see if we could visualize the cuff adequately. With all these artifacts and with all the sutures which were put in place, the radiologists were not sure what they were seeing. We then consulted the MR consultants and they said, look, there's a lot of metal there and we can never be sure what's the status of the cuff. So you make a call on table. Next, please. So the question is, what do we do now? We've got this lady who is diabetic, insulin dependent, CKD. Within almost 8 weeks after the index surgery, she's now left with this situation. So the question was, should we refix this? Should we remove it and leave it alone in view of her medical issues? Should we attempt a shoulder arthroplasty, or we do a reverse? So let's just take the opinion of the house or the panel, if I may, just for 30 seconds at this stage. Dr. Mohanty.
I would like to do a reverse.
Okay, so my question to you is, what is the data supporting the glenoid base plate integration in a renal dysfunction patient where the bone stock is inherently poor? And what are the long-term results on that? Anyone else?
Harshad, do you have experience on this?
Yeah, really, it's a little complicated case to have an opinion on. I mean, I'm sure Parag has handled it well. But with a failed implant and shell of a bone, I am also in favor of replacement. And I do agree with Parag when he says that integration in a renally compromised patient is always going to be an issue. But that option is the one which comes to my mind now.
Primarily, Arshad, would you have fixed it with a plate?
Plate, again, if I had to use a plate over here, I would have definitely needed to use a fibula graft or some kind of graft so as to shore it up. But even then, the chances of failure in this are reasonably high. Really don't know how this will behave.
Okay, so next slide, please.
Parag, can I comment?
Yes,
yeah, please.
Now, pertaining to your question, in the same implant, you can retain the stem, and then on that, probably you can put a hemi or a reverse. That option is there. But whether it is available here in India, I am not sure. Second, the coracoid looks very good here. So for your glenoid, the purchase of the central peg or that coracoid screw would be very good in spite of she having those CKD and other issues.
So are you saying that you would now embark on a reverse shoulder?
Yeah, reverse shoulder would be the option now. And if you see the last X-ray, the lateral view, the trochanters are flowing, the tuberosities are, the lateral view. Probably, yeah, they're there. The next one. If you see the tuberosity, which is flying off, probably how much function it will have, we are not sure. The next X-ray.
Go forward with the circle.
Yes, here. Yeah.
Okay, so fair point. You would go for a reverse, and Harshad also would go for some kind of an arthroplasty. So we really counseled her. We took her up on table. Now, all these aspects, what you were saying, we had addressed. So I had contacted the company and I said, look, can we retain the stem and convert this into either a total shoulder or a reverse? And the answer to that was no. So when I went inside there, we found, as you can see on the picture, the second from left, the head had flopped off, which you could see on the x-rays as well. The next question was, will this stem come out easily or is it a nightmare? At about 9 weeks now, post-index surgery, the stem just came out in my hand. And 3, when you look at the stem, there was no bony integration, although one would not expect at this stage. At 3 months, I couldn't see anything there. And the head was just a devitalized shell. So this whole thing came out in my hand. And then the question was, what do we do now? I had the whole armamentarium ready with me. Next slide, please. So this was the C-arm picture. As Sangeet mentioned, I was keen to see what is now the residual GT remaining and what's the status of the cuff. Next, please. So the cuff, I had a very good look from all sides, and I couldn't see any tears, and it was fairly robust, although a touch atrophied. And I said, looking at this cuff and the GT, let's just go and see if we can get away without a reverse in view of age. Next, please. So on table, we reamed it. Mind you, the primary surgeon, I think when I spoke to him, he had cracked it, and therefore the circlage out there on day 1. And although this was the smallest stem which he had used from this company. Next, please. So, I prepared the whole thing. We've got the stem down in, and then I converted this into a shoulder hemi. Next, please. So this was the intra-op picture. Next again. This is the immediate post-op. Next again. So, the dilemma here again, look at the scar. So when I first took her up, I was not very happy with the approach, but we are where we are. And I said, look, what is the best way out? So if you see the scar on the right, I had to curve it a bit more anteriorly, meandering away from the primary incision. And then the question in my mind was, will this heal or will this break down? And if you have a nice 45-degree angle, the scar heals very well. Next, please. So she continues to improve. This was her Feb 20 when she had started with rehab at home. And that's when the pandemic struck in March. Next again. So this is the home video which she had sent me in September via her daughter. I said, look, how much can you lift up and please continue with your therapy. Next, please. You can see how functional she is. She's saying, I'm doing everything by myself. She lives alone with her husband. So coming to the discussion, there are 2 issues. Is this an implant failure or is this a technique failure on behalf of the surgeon? And, looking at this clearly, I think the surgeon did not get it right. So my question now again to the panel is, has anyone had a similar experience? Or 2, if someone who's using this device regularly, what tips would you give to make sure that the head remains screwed on the sprockets very well without it flopping off? And the third question is, literature review about this implant really doesn't exist. So, I went through Cochrane, we went through PubMed. There is no long-term documentation. For that matter, there is no medium-term documentation as well. And, when I spoke to the French surgeon who had done this and I emailed him that, look, we've had this, although I'm not blaming the device, what would you say? So he says, look, we've had a few cases, but we are on a learning curve as well. So let's have the opinion of our faculty as to what they think of this device. I'll give it to you, Dr. Mohanty.
Yeah, thank you, Parag. That was an excellent case. Good outcome, good, salvage situation of doing a hemi. Actually, it has not thought up to my mind or any of our panelists' mind as well. And just to start with, Sangeet, would you have done to start with a unique prosthesis, or you would have done a plate fixation? Like
if we can go back to the first X-ray, the problem why it has failed, we can discuss. Post-op X-ray. The success of the prosthesis or the implant is it has to be the post-op. On the left-hand side. Now, this was never reduced anatomically. So the central part of the plate has to be in the center of the head. If it is like this, so it is bound to cut out. So there lies the key why it has failed. So it was never reduced anatomically, and the center of that proximal part of the implant has to be in the center of the head. If it is like this, it will cut out. That is the key.
Dr. Mukhi tells that it is in varus.
Oh, varus, yeah. Yeah, it was in varus. And that is why it is not acceptable. It is a day one failure. And this implant,
can you
according
move
to
on to the next case?
Yeah, no, I would. May I talk one thing? This implant is given up in France.
Thank you, Dr. Sangeet. Thank you, Parag, for that an excellent case. Let us move on to the next case by Dr. Basan Bhuyan due to shortage of time.
Okay.
Yeah, in the while Dr. Basan is sharing the screen, you can give your comments.
Yeah, this implant is given up in France. According to Boileau, he doesn't use it. And you see the approach which was used first has a deltoid nerve palsy. So her abduction can never go beyond 90. The anterior part of the deltoid is paralyzed. If you go to the X-ray, you will see the whole deltoid wasting. And EMG and nerve conduction should have been done before doing hemi.
Yes, sir.
Do you agree?
We had done the axillary nerve assessment on EMG, which was normal.
Normal?
Yes.
Yeah, but yeah, that is all right. Thank you. Thank you.
Thank you. Dr. Basan, please. Could you unmute yourself? We are not able to hear you.
Dr. Basan, please unmute yourself. Please press the unmute button, Dr. Basan.
Yeah, handing on that.
Yeah, you are unmuted.
Am I audible now?
Yes.
Yeah.
Hi, good morning, everyone. I am Dr. Basant, Professor and Head from the Department of Orthopedics and Trauma from GMARS Medical College, Himatnagar, Gujarat. And today I am presenting a case of severe form of slipped capital femoral epiphysis treated by modified Dune osteotomy through the SAP surgical dislocation approach. My sincere thanks to President and Secretary of the Bombay Orthopedic Society for giving me this opportunity. So coming to the case, this is the case of 16-year male, chief complaint of limping since 6 months, pain around left hip joint and anterior thigh for 6 months, and there is limitation of movement of the left hip for 6 months. On examination, the gait is antalgic gait. The foot progression angle is externally rotated. And on further examination, the anterior superior iliac spine is at the same level. There is no local rise of temperature over the left hip joint. The anterior joint line tenderness is present. Level of trochanter, that is on the left side, it is migrated proximally as comparison to the healthy side. The flexion of the affected hip joint is from 0 to 110 degrees. There is external rotation during flexion of the left hip joint, that is the Drehmen sign is positive. There is limitation of abduction and internal rotation of the hip joint, and there is comparatively increased external rotation of the affected hip joint. On measurements, the limb length discrepancy is approximately 0.5 centimeter. Coming to the special test, the Trendelenburg test is cannot able to elicit it due to the pain. And the Patrick test or the Favre test, it's positive, which signifies that there is femoroacetabular impingement is present. So the clinical diagnosis is slipped capital femoral epiphysis of the left hip joint. But to come out upon the differential diagnosis, that you should think about the tuberculosis of the hip joint, the leg cave perthes disease, and the epiphyseal dysplasia. So the next point of investigation, we go for the radiological examination, both the anterior posterior and frog-like lateral view of the hips. On the anterior posterior view, there shows widening and irregularity of the physis, and the height of the epiphysis on the affected side, it's quite decreased as comparison to the normal side. Metaphyseal blanch sign or the still sign is positive in epi view. And on the frog-like lateral view, there is posterior displacement of the epiphysis as comparison to the metaphysis. The metaphysis is appeared like a hump shape, and there is certain amount of remodeling also present on the posterior aspect of the metaphyseal area. So these are the different lines. The Klein's line, which is a horizontal line, which is passed through the superior aspect of the neck of the femur, which normally transects some amount of lateral part of the epiphysis. The Trithovan sign is positive on the left side as the epiphysis is displaced inferiorly and posteriorly. Then this south peak slip angle, it's quite important to see for the severity, whether it's the head shaft, basically the head shaft angle differences between the normal side and the affected side. If the angle difference is between 0 to 30 degrees, then it's a mild variety. If it's a 30 to 60 degrees, it's a moderate variety. And if it's more than 60 degrees, then it's a severe variety. So here, the head shaft angle is approximately 50 degrees as comparison to the normal right side. So this comes around the moderate severity. Then we go for the both two-dimensional and three-dimensional CT scans. It shows the deformity of the proximal femur and the version and orientation of the epiphysis. And in CT scan, you can able to accurate measurement the head neck angle, and you can also appreciate the metaphyseal remodeling, and which helps you for the plan of management. Here on the two-dimensional CT scan, the head neck angle is approximately 80 degrees, and which is very significant. And here it comes as a more severe variety of the slipped capital femoral epiphysis. And on the three-dimensional view, you can able to appreciate that there is inferior and posterior displacement of the epiphysis as comparison to the metaphysis. Other investigation we
Dr.
planned.
Basant, can you please be a little quicker, because otherwise we will have to cut down the discussion time.
Sure, sir. Yeah. Sure, sir. I will quick as possible. So other investigation will go for the routine hematological examinations and the assessment of the both endocrine and the metabolic assessment, which comes out to be normal. So the diagnosis is it's a stable slip capital femoral epiphysis in a severe variety. So coming to the management and the different goals, the main goal is to prevent further slip, to correct the deformity, which helps for the hip stability, and to avoid the complications like the avascular necrosis and the chondrolysis. So the plan of management here, mainly it is for the surgical intervention. In situ pinning and the epiphysiodesis, it's mostly for the mild to moderate variety cases, but here we are mostly planned for the proximal femoral osteotomy. And the proximal femoral osteotomies, it may be there are the different levels. At the physial level, whether it's a
Please show that what you have done. Just
okay, okay.
Just show that. Okay.
So here I would my plan was a modified done procedure by open reduction, surgical dislocation of the hip joint. I go through the extended retinacular soft tissue flap preparation, protecting the epiphyseal vascularization, and I reorient the epiphysis by shortening of the femoral neck and dissection of the posterior callus, followed by the internal fixation. So this is the position of the patient in a lateral position. Expose the abductors and the vastus lateralis. Do a trochanteric flip osteotomy. Then I expose the hip joint after a jet capsulotomy. And these are the retinacular flap preparation. You should be very careful during the dissection because the vessels are there on the posterior superior portion of the neck. So after making the retinacular flap preparation, I go for the femoral neck osteotomy. So this is the osteotomy, femoral neck osteotomy, and remove the posterior callus. Then I reposition the femoral neck, the epiphysis over the femoral neck, and then I see for the perfusion of the femoral head. So this is the perfusion of the femoral head. You can see, you can drill the femoral epiphysis in a 2 millimeter drill bit and see for the bleeding, whether the bleeding is present or not. Here the bleeding is present, so the perfusion is adequate. So I fix after reduction, I fix the epiphysis with two 6.5 millimeter partially threaded cannulated screws, and the trochanteric osteotomy is fixed with two 4 millimeter cannulated screws. So these are the post-op protocol, post-op dressing and drain removal after 48 hours, quadriceps and demobilizing exercise started as soon as possible.
Let's see the X-ray.
Yeah, I'm coming, sir. Then after that, we start with the non-weight bearing ambulation, and these are the review for the radiological assessment. So these are the immediate post-op X-rays, both anteroposterior and lateral view. So the epiphysis is well aligned and the screws are in good position. And these X-rays after 6 weeks of post-op X-rays. So to conclude, the modified Dune osteotomy is a well-accepted technique. It's a safe, efficient, and a reproducible procedure. It restored the proximal femoral anatomy. It reduced the articular cartilage damage, long-term survival. So it helps for the long-term survival of hips. But it's a technical demanding due to its surgical complexity. And this is a viable treatment option for moderate to severe cases. Thank you for your kind attention.
Thank you, Dr. Bhuya, for that excellent outcome of your surgery. I allow only two comments. One, Dr. Mandar, please, followed by Dr. Swapnil.
Yeah, Dr. Bhuyan, thank you for this case.
You're welcome.
Excellently done. I would just probably caution all the delegates to, be very careful in planning this procedure for a chronic slip, because chronic slip by definition has a very, very less chance of avascular necrosis. So any avascular necrosis which is caused post-operatively is usually iatrogenic. So we have to be very, very careful in doing such a technically demanding procedure straight off in a chronic slip. It is the other thing is probably better to do a slight trochanteric distalization, I think, which you have not done when you have fixed the trochanteric osteotomy. So that helps in tightening the abductors and giving a better, lesser abductor lurch post-operatively.
Thank you
Thank
for
you.
your input. Thank you very much.
Thank you. Could you just stop sharing your screen while Dr. Mukhi is sharing his screen for the next case? May I have Dr. Swapnil's comments or any suggestions?
Yeah, so probably there was still some amount of under reduction I felt. Probably there was a kind of a sagging rope sign which was there. So whenever you're doing and attempting this procedure, try and get the best possible reduction, no virus, so that this doesn't fail.
Okay. Thank you.
Okay, thank you. Thanks a lot.
Thanks, Swapnil. Thank you, Dr. Bhuyan, for excellently showing the intraoperative steps there, which was very clear. Thank you. Now over to Dr. Mukhi for his case.
Yes, thank you for allowing me to present this case. This is a 46-year female who was operated elsewhere for arthritis due to systemic lupus erythematosus, and she's on steroid therapy. She was operated 6 years ago. Previous records are not available. All movements of the hip are painful on the right side, and she's not able to walk, and the pain is so much that she's not able to sleep in the night. There is no fever, no symptoms other than this pain, and all her blood parameters are normal. Next.
Please
Next
click
slide.
on the screen. Please click on the screen. Yeah.
This is the X-ray, which is the taken out over here, which is showing that the right side has, the head has migrated up, the cup is vertical, probably loose, the top screw has moved, and this is the picture. I want to have the opinion of the house.
Yeah.
One opinion, Dr. Mohanty, sir.
Yeah. How old is the year? How old is
46,
surgery?
46.
No, how old
6
is the
years.
surgery?
6 years.
So could you
Okay.
put the X-ray again so you can see it?
Yeah. We can see the cup has moved from here to here. The screw has also moved, as well as this has gone up and the cup has become almost vertical.
So this is a debonding of the cup. This is a aseptic loosening of the cup, and because of that, the head has dislocated.
Yeah.
And I would do a CT scan first to assess the positioning of the stem, and anyway, it requires a revision surgery because the cup position is altered.
Yeah. So this is what was done. CT scan. Any opinions?
Has the poly come out somewhere? What
Yes.
has happened to the poly?
Poly has come out, and the metal is touching the ceramic head.
So is it a wear or it is a dissociation of the poly from the shell?
It's a wear.
6 years, so much of wear. It is hard to buy. 6 years usually, it should not be so much of wear.
Yeah.
Okay.
I did the CT scan.
Yeah.
And I did the MRI scan, Mars MRI. Any thought process?
Why a Mars MRI was done? To see what? What
To
are the
see
indications?
the fluid levels there, and whether it was involving any of the soft tissues around, because I was suspecting little bit metallosis in my thought.
Did you do the cobalt and chromium levels?
No, I did it. It was normal.
Okay.
Yeah. And this is what I got on the opening. No, I was stunned.
Okay. So
Totally stunned.
That was the metallosis because the ceramic was rubbing against the metal.
Metal.
Yeah.
And the cup head were worn out because the head used was the large size head and the poly that was just 6 millimeters.
Yeah.
This is a video.
What was the size of the cup and size of the head?
The size of the head was about 50 and the cup, a poly cup was of, a head was 40. So the poly that was there was, yeah.
Okay. Oh, that was the problem.
Yeah.
So minimum, one should have try to keep 10 millimeter of poly on either side.
Either side.
Yeah.
And this is what I got. See, the whole poly has worn out from here. And this is the wear. All the screws were loose, the cup was loose, and this was the metal which was rubbing.
Yeah.
Against the ceramic. And you can see the stripe wear on the ceramic.
Correct.
I haven't seen this in my life on ceramic on poly.
So actually, ceramic rubbing on metal, na?
Yeah.
Ceramic on poly. Poly has completely worn out.
No, that is because, it was a very thin polyethylene. Was it a highly cross-linked polyethylene? Or?
This was, yes, yeah. Yeah.
Now the question here which I would want to ask is, suppose you have put a cup which is 40 size and you have no choice but to put a liner which is thin.
No, you have to reduce the head size. In 40 size cup, you have to use 22.
Exactly, but the liner itself will decide the size of your head. Na? You can't have a 22 head and a liner.
You could have easily gone for 28.
No, ceramic, if you're putting, then you can put 28 head. If it is ceramic. But if you're putting ceramic on poly, it has to be 22.
So the ceramic has to be either 22 head or you have to shift to a metal head if it is 22 size.
The metal head, what is the liner? Liner, if it is ceramic, then ceramic on ceramic, you can allow 28 head to be used. But if it is a poly liner, then it has to be 22 head, either your ceramic or metal, whatever. Because 40 minus 22, it comes to
6 millimeters.
Only 16 millimeters. So 16 millimeter on either side, it will be 8 millimeter. So minimum 8 millimeters on either side, considering the annual poly year to be 0.5 millimeter per year. So it may last, we expect to last 16 years unless there is some other problem.
Have that option available on paper.
I have a query.
Yeah.
Now, if you see the metal shell, it has a provision for 3 screws.
Correct.
Yeah.
And they should have gone in the ilium. Now, if you see the X-ray, can you go back to the X-ray?
Yeah.
Yeah. Can you see where are the screws going?
They have moved.
That cup has moved.
Cup has moved.
The first post-op X-ray.
No, that I don't have. No, I told you this is all that is available. Yeah.
How can you comment it as how can you comment it has moved?
There you see. This is the point.
No,
unless you see the earlier X-ray, you cannot compare. You have to see serial X-rays in order to comment.
No, sir. Probably this must have been fixed in this position itself. That is what I'm trying to tell. And that may be the cause. Yes, and that may be the cause of so much of wear.
No, you can see the halo of the screw here.
No, then you will have a big void in the acetabulum. The screws have moved so much, there will be a big void in the acetabulum.
Okay, let's move ahead. Yeah.
Now what to do?
The message is that one should look at serial X-rays in order to comment on the movement of the cup or osteolysis or whatever. Serial X-rays has to be there.
And now what to do?
Now, depending upon the, your bone defect, you have to reconstruct. What is the bone defect?
And the bearing. And the bearing.
Bearing, you can do ceramic on ceramic or ceramic on polyethylene.
Yeah. Again poly? No, I was afraid of using poly again because there will be some metal particles left over which can go into the interface again and cause the problem. So I won't use poly when there is metallosis. I will have to use a hard bearing, and I opted it for ceramic on ceramic with bone grafts from there, and I used the regular cup.
The stem was well fixed?
Yeah, the stem was well fixed. The trunnion was normal. There was no trunnianosis. That was the
there is some amount of osteolysis around the calcar region on both the sides.
Yeah, that is on both the sides, but it was very well fixed. There was no point in.
Correct. But I would suggest that inferior most screw which you have put, you should have put little horizontally so that it goes through the iliopubic rami. That is the technique, in revision situation. That is, we learn it over by evolution, not by revolution. Gradually, one must learn this technique. to pass the screw into iliopubic ramine. That gives a
And-
good fixation inferiorly.
Yeah. I wanted to pass it in the ischium also. I passed the two lower screws.
No,
But
you
then
cannot,
again,
it will be difficult because unless you have a
difficult.
peripheral hole. But iliopubic ramine definitely can pass in a multi-hole cup and can pass through that.
Yeah. And it gave me a good fixation. And I did the grafting also. And this is the X-ray after 2 months. And
Do you
she's
have
doing
long follow-up?
well. 2 months.
Okay.
Just I wanted to produce that metallosis, how devastating it is. The whole gluteus medius, oh my God. I was thinking it would have been eaten away if I had waited long.
The
No,
side
because
cup
this
is
was
also
a,
working for revision.
this was not metal on metal. That's why.
Yeah.
Metal on metal here.
Yeah.
Okay.
Yeah.
Well done, case. Thank you. Let's move on to
And
the.
this
Thank
is the
you.
video if it plays.
Yeah.
Yeah. I put the board over there for not showing the
Why
face
she
and
is
Monty
walking
said-
non-word bearing? Why she is
Yeah,
walking?
I have to be a little more careful, in a failed case. And
No,
opposite hip also, I'm worried.
It was,
Because opposite, yeah.
If it is a cup which is well fixed, well positioned, I straight away give weight
Still,
bearing. Weight bearing
no.
will promote the osteo
Don't touch.
integration of the cup.
Actually, at home, she gave me a video that she was walking even without a stick. But I was worried. I told her, no, please take the stick and do a toe touch, partial weight bearing. Yeah.
Okay. Thank you.
Okay. Thank you.
Thank you. Let's move ahead with the cases.
I
from
must thank the
both
Bombay
post-
Orthopedic Society for allowing me to present it. It was a late presentation. Sangeet Gawale gave me the permission. Okay, we'll accept it. Thank you, Sangeet.
Thank you very much. Thank you. Let's move ahead with the case from the host institute. There is one case remaining. Dr. Power, should we go to Dr. Bipul's case or whatever?
Yes, sir. Yes, sir.
Dr. Bipul said your case was remaining. Can you please share your screen?
Unmute yourself.
Hello.
Yeah, please. Please do slideshow and go ahead.
Good afternoon, respected faculty. Is my screen visible?
Yeah, you are visible and audible.
My case for today is a case of adult painful hip dysplasia. This was a 30-year-old male who presented to us with right hip pain since 8 years, aggravated since 8 months. Patient was unable to squat or sit cross-legged. There was history of painless limping ever since he started walking, for which he never sought any medical attention. On examination, we noticed a supratrochanteric shortening of 3.5 centimeters. The range of motion was restricted and globally painful. Patient was walking with a bipedal entalgic assisted gait. On the radiographic imaging, we noticed a deformed femoral head with a shallow unformed acetabulum, very typical of a neglected dysplastic hip, with a narrow femoral canal, significant shortening, and osteopenia. As far as dysplastic hips are concerned, there's cross classification to classify the amount of dysplasia and amount of slip. This particular case, when we calculated, we noticed that this was a Cross type 1 with around 25 to 30% displacement. So what were the challenges that we were expecting pre-operatively during the surgical procedure? We needed to do a pre-operative on-table adductor tenotomy before proceeding with the case, because then otherwise intraoperatively we would not have enough movement. Also, there was a formation of a false acetabulum that we could see in the X-ray. So we needed to ream into the acetabulum proper in order to restore the normal center of rotation of the hip. At the same time, we would also be concerned that since the patient had a 3.5 centimeter shortening, we were concerned about sciatic nerve stretching causing some amount of neuropraxia probably, which we will have to look out for. So this is the immediate post-operative radiograph. We were able to restore the normal center of rotation of the hip in this case. We got away with the 46 mm acetabular cup and a 28 mm head. Intraoperatively, we noticed that around 30% of the cup was remaining uncovered, which we managed with the femoral head autograph taken from the patient, fixed in place with two 6.5 mm screws. In the post-operative period, we were able to give the patient a lengthening of 3 centimeters, which meant that the patient was left with a slight 0.5 centimeter shortening. In the post-operative period, the patient did develop foot drop, which we guessed was secondary to the sciatic nerve neuropraxia due to stretching, which was managed conservatively, and the patient recovered completely from it in due course in 6 months. These are the follow-up radiographs at 3 months, 6 months, and at 1 year follow-up. We can see that there is no loosening of any of the total hip replacement components, including the cup as well as the stem. There is slight resorption of the graft, which is noticed laterally, but that is lateral to the border of the acetabular cup. This is the range of motion photographs at 1 year follow-up: flexion extension, abduction adduction, internal and external rotation. This is the gait video of the patient walking. As I mentioned, the patient was left with a slight 0.5 mm shortening. So therefore, the slight lurch that we can see. The patient is presently pain-free and able to do all his routine activities. So just to summarize, in Crow's type 1, we usually go ahead and do a regular total hip replacement. In this case, just to be on the safer side, you have to keep smaller components ready, because in cases of developmental dysplasia of the hip, we expect that the component acetabular as well as the femoral would be smaller than what would be required in a regular case. In the Crow's type 2 and 3, there might be necessary need to add on subtrochanteric shortening procedures sometimes, as well as in Crow's type 4, it is absolutely necessary that the patient will be needing subtrochanteric femoral shortening procedures. A few of papers in the past have supported uncemented total hip replacement in cases of developmental dysplasia of the hip. So right now we are going ahead with uncemented replacement as compared to cemented in the past. Thank you.
Thank you. Thank you, Dr. Seth. That was an excellent case. Couple of questions. Just first thing is that when did you decide to put the graft? After putting the final cup in?
Yes, sir. Even on the trial, we had noticed that there was some amount of uncovering. At the same time, on putting in the final cup, we went ahead and put in the autograph, sir.
Yeah.
This was a non-structural. This was a non-structural autograph, sir. It was not in the weight-bearing area.
Yeah, yeah. No, that a couple of the important recommendation is that for the benefit of the viewers, that you remade, put the trial cup, then you decide about the graft, and the trial cup being in place, then only put the graft. And while putting graft, one should see that the graft should not extend beyond the margin of the cup. As you told rightly, that the graft gets absorbed if it is non-weight-bearing portion beyond the margin of the cup. So graft has to be weight-bearing in order to get incorporated. And number two, the screws has to be directed towards the sacroiliac joint or along the trabeculae of the bone. Then the problems of the screw doesn't arise. Here the screws appear to be little horizontal, but one should direct the screws along the trabeculae so that the problems of the screw breakage and all these things, loosening of the screws doesn't arise. And size of the cup is usually decided by the anteroposterior diameter of the acetabulum in dysplastic cases, because the anteroposterior diameter, that is less compared to superior inferior diameter, and that holds the cup, that gives the fitting of the cup. So when you see the anteroposterior diameter is good enough, the cup is holding well, then superiorly you decide to put a graft. And after putting the graft, again you can just rim little bit and put your final cup in during that time. And you could have prevented the sciatic nerve problem if you would have accepted little high center of rotation. The recommendation is that probably it was not Crow type 1, probably it was a Crow type 2 or type 3. Because type 1 and type 4, the recommendation is that you try to restore the center of rotation anatomically. Crow type 1 is directly possible. Crow type 4, you do a subtrochanteric osteotomy and try to restore the center of rotation. Where type 2 and type 3, these are the two types where you have to accept a high center of rotation if your sciatic nerve is at stake, and you should not lengthen beyond about 3 centimeters or so, or 1 inch, maximum 1 inch, 1 inch to 3 centimeters, something like that. You should not allow lengthening, otherwise that usually lands in the sciatic nerve problem. Any comments, Dr. Mukhi, please?
Unmute yourself. Sir, unmute.
Yeah.
To release the gluteus maximus insertion to the linea aspera. If you don't release that, then you get that neuropraxia of the sciatic nerve and the vascular damage in 3% of the cases. And one more trick I want to give you is that you start reducing with 22 millimeter head. Wait for 5 to 10 minutes and see the tension of the nerve. Then put +1, +2, +3, and then go to your 28 size. In this way, with the knee flexed, you will not cause the sciatic nerve palsy. And when you are reducing the head, you must tilt the table towards the surgical side or the surgeon side so that you don't give any traction. It automatically reduces with a snap. This is a very good trick for osteoporosis as well as for this type of hips tight reduction.
Okay, thank you. Thank you for your comments. Thank you, Dr. Seth. Due to constraint of time, we should move ahead. Yeah, while Dr. Amit Yadav is sharing his screen, Dr. Sangeet, your comments, please.
Usually we are not prepared for 22 head, which are often required because the size of the socket is very small.
So you just put the trial, just lengthen it by minus, +3, begin with minus.
No, sir, I'm not talking about that. These are dysplastic.
Yeah.
So your size of socket is very small, required.
Yeah.
So in the bargain of making the available socket fit in the acetabulum, we try to rim more and more and take out the host bone.
No, you're not understood by a thing. Whatever trial you have put in.
So that is different thing. I am talking different, sir.
Okay.
Yeah. Correct.
Gradual lengthening,
Yeah. Thank you. Thank you. Let's move ahead with Dr. Amit's case. Yeah. Dr. Amit, please.
What was the bearing surface? Ceramic on poly or ceramic on ceramic?
Metal on poly.
Metal on poly in a young person. I would disagree.
Yeah, it would have been better, but sometimes in public hospital, due to monetary constraint, we have to use metal and poly. Point is well taken.
Sir, I am audible.
No, but the revision is going to be very difficult in a public
visible
hospital.
and audible. Yeah, we understand that, sir.
Should I start?
Yeah, please.
Good afternoon, everyone. I am presenting a case of peri-implant fracture of humerus. A 25-year-old male came with complaint of pain, swelling, and inability to move right arm following a road traffic accident. There was no other associated injury. There was no wound, no distal neurovascular deficit. So X-ray AP and lateral view showing the distal 1/3 humerus shaft fracture with no neurovascular deficit. So we operated the patient through posterior approach. 2 leg screw was put and plate was done in neutralization mode. After 3 months of surgery, patient returned to his job, continued daily activity, but unfortunately had a fall directly over the shame arm. This X-ray showing the proximal 1/3 humerus shaft fracture with implant in situ with no neurovascular deficit. So what are the treatment options for this case?
Go back to the X-ray. Yeah.
Yeah, Dr. Sangeet, you can.
No,
why did it fail after all?
So patient has trauma history, significant trauma.
It has not failed. He had another fracture at a higher level.
Sir, for this was initial fracture. This was operated. Then again he has fall 3 months after primary surgery. This is another
Just
fracture.
show the first X-ray. First X-ray pre-op, please.
Yes, sir.
Okay.
Post-op.
Dr. Ram Prabhu is there? He has left. Okay. Dr. Harshad, your opinion, please.
Show the failed X-ray, the one which shows failure. So this is a new fracture. Na? Your initial fracture has healed up completely. And is the screw broken over here? The second screw from the yeah, both screws are broken.
Both screws are broken.
So I think that's related to the fall, not related to your primary fixation.
No, the screw cannot break. Screw can come out of the bone, but it cannot break.
It can break if the quality is not good.
No, yeah. Quality, still it will not break. It will pull out of the. That's why I'm saying that this is
Was
a
the
stress.
fall a very violent fall?
So it was a significant trauma to patient.
So then I think we attributed it to that.
Okay, what would you do now?
This will require a revision. You have to take it all out and put a new plate on it and try and bypass the old fracture also and the new one also. So a longer plate would be my choice for this one.
Same approach?
Same approach. Posterior approach. Posterior approach.
Akshay, this extra-articular plate is not longer beyond this. This is the longest available synthesis plate.
So I get your point, Sangeet. So I will not put those screws in the curved part. I will put a straighter plate, which will be a longer, not longer than this, but long enough plate which will go up to and cover the distal fracture which was initially there. So I need not go all the way to the lateral condyle here. That's what I'm trying to say.
So you go until the superior aspect of the olecranon fossa, supracranial till olecranon fossa, not beyond that. Okay.
My choice would be plate over the plate. Have you done that?
Could I proceed?
Yeah,
please.
I have done plate over this plate.
Please proceed. Yeah.
So as Arshad sir told, there was a posterior option, but plate was not available. So we operated the patient through deltopectoral approach, and Philos plate was done, and 2 leg screw was put through this. So this follow-up after 1 year of secondary procedure, AP and lateral view showing the radiological union of both the fracture. This video showing the good shoulder function. With good elbow function.
Good, very nice.
I think it is very nice.
Yeah.
Same clinical picture showing the elbow function. This is scar of deltopectoral approach and scar of the previous approach.
You can't dispute a good result.
So we did a review of literature. We find a case series on plate osteosynthesis for treatment of no-nil plate fracture, in which they operated a proximal humerus fracture with Philos plate. Then patient has again history of trauma and developed a fracture at distal third. So they removed distal 2 screw and apply another plate. Similar was another case of 82-year female operated with Philos plate for proximal humerus, in which they removed the distal 3 screw and proximal 4 screw and apply another plate of same dimension but length, more of length, and they apply screw through proximal 4 and distal, and they get good result.
But this was not plate over plate. This was side by side.
Yes, sir.
It's another approach and another fixation. Yeah. Yeah.
What I was talking about is plate over plate.
Yeah. Okay. That was an excellent outcome while Dr. Samir Panchal is sharing the screen.
Thank you, everyone.
Yeah. And probably he will avoid using a half sleeve shirt or sleeveless shirt. Yeah, Samir, you can do a slideshow and start presenting. Samir, we are unable to hear you. You unmute yourself. Yeah.
Sir, can you hear me now? Hello.
Yeah, yeah. Just make slideshow and then go ahead.
Sir, yes, sir. Sir, I'll be presenting a case of infected non-union of radius ulna shaft fracture, which is managed with the DCP plating and autologous iliac crest graft. Sir, patient 30-year-old male, right hand dominant. He works as in a courier and logistic services. Came with a complaint of pain and swelling of left forearm since 1 day. There was alleged history of fall from bike. Sustained a blunt trauma to the left forearm. There was no history of any other significant trauma and no other comorbidities. So these were the X-rays. So surprisingly to our notice, sir, patient also had a proximal radioulnar joint synostosis. So for this reason, we also advised the X-rays of the opposite arm, and the patient had a unilateral proximal radioulnar synostosis, which was congenital, sir. We have operated the patient with 3.5 DCP, and an additional lag screw was put for the butterfly fragment of the radial shaft. So these are the immediate post-op X-rays. The suture removal was uneventful and patient has been discharged, sir. Patient complained of a discharging sinus from the volar aspect of the wound from the radial plate surgical site 3 months post-op, sir. And this was the picture, sir. He came with this picture. There was plate loosening with an active purulent discharge from the volar aspect.
What was the role of radioulnar synostosis in this case?
Sir, there was no role. It was an incidental finding, sir.
Okay. So now it is an infected,
It's an infected non-union.
Infected non-union. Okay. Yes, Dr. Mangal, your opinion, please.
The X-ray, na beta.
Dr. Mangal.
Yeah, unmuted now.
Yeah. Is there?
Yeah. The radius ulna, I think in this particular case, the proximal synostosis is relevant because now it's not a 2-bone forearm, it's almost the equivalent of a 1-bone forearm because there is no rotation of the radius around, So in that sense, it probably has a bearing on what you would do. I think this fracture becomes a little more easy to stabilize. Otherwise, in a regular radius ulna, the radius is rotating around, so there is a significant amount of torsional issues involved. Here, this is just two straight bones relative to each other, which can be fixed.
Primarily, what you would have done then?
Primarily, I would have done exactly the same thing in terms of fixation.
Okay. And right now, after infection?
After infection, then you have to go down the usual path of debridement. Depending on what the gap is, then you have to fill in the gap. For a small gap, I could probably use a tricortical graft. For a longer gap, I would probably be looking at a vascularized fibula, depending on how big the gap is.
But you will do same stage or 2-stage procedure?
Two stage. Here
yeah, first.
We've got good vascularity and all that. So I would prefer to do it 2-stage.
Correct. Yeah.
Shall I proceed with the further?
Yeah. Please proceed.
So, sir, basically, with this clinical background, we have planned for an implant removal and a thorough debridement. Intraoperative samples were collected and they were sent for pus culture and sensitivity. And post-operatively, antibiotics were started as per culture and sensitivity. It came out to be a gram-negative organism, Klebsiella, which was sensitive to meropenem. And this was the immediate X-ray after the primary debridement. So we have not done any temporary stabilization in the form of external fixator, sir, in this patient. We have immobilized the patient with an AE slab for 6 weeks.
But you could have put antibiotic impregnated cement there, like
sir, we could
technique.
have, like the idea behind not putting the antibiotic cement was we did not wanted this can be done. This could have been done in a 2-step procedure, but for that thing, we again had to remove that antibiotic cement pellets.
Second stage, you take out the antibiotics and go ahead with the final fixation.
Yes, sir. The spacer could have been put here.
Can I just make an
external fixator?
Yeah. Sangeet followed by Dr. Mangal. Yeah.
So, only cement spacer is not going to work. You have to add up a fixator or some implant, either internal or external. So then
what we do, we put a K-wire and like you prepare a cement oil over that. So K-wire, just a little bit of K-wire projects inside the proximal and distal fragment. That stabilizes. You don't have to put a fixator there, whatever gap is there. And then we do the second stage after taking out that, putting a fibula graft or whatever with the plating.
So vascularity is not an issue in forearm because it is all covered with good muscle envelope.
Yeah, yeah.
So the idea was after debridement, probably we could go early and do a definitive fixation at 3 or 4 weeks. It took a longer time. And by avoiding a spacer, and we never thought it would take 6 weeks time. Mangal.
Yeah, my sort of thing is that now wherever I want to go in again and add any kind of bone graft, I normally like to use stimulant, that is resorbable bone pellets. But these are exactly the cases where I will use a cement cylinder, because otherwise you have to do a lot of dissection there. The moment you use a cylinder, you've got an empty space into which you can put whatever it is that you want. And the amount of dissection that you need to do becomes minimized, and you have the advantage of an induced membrane. Even if you're going in 3-4 weeks later, you've got a good vascularized membrane which will, provide vascularity to whatever it is that you put in.
But Mangal, the induced membrane can only form if there is a stability given. In the presence of mobility, it doesn't form. That is what is the original principle of Mackay.
True. So you have to do both. You should do both. It doesn't take much to do, because anyway you are going to go in. Second surgery is a given. So when you do it the first time, I try to make it easier for me when I go in the next time.
Correct. That maintains the soft tissue envelope, and also it will maintain the radial length. That will prevent radioulnar variance. In this particular case, the gap is more in radius compared to ulnar.
Yes, sir.
So that will maintain the radioulnar variance also. Yeah, please go ahead.
I want to know whether the infection was both radius and ulnar, or was it in only radius?
Sir, the discharge was originally from only the volar aspect radius side, but as we can see in this picture, we have removed both the plates because ulnar plate has also given up, sir.
Yeah, but you should not have touched the ulnar at the same sitting because of the infection. So what I would have done is either you touch the ulnar only, pass the nail, remove the plate, and then tackle the infection anteriorly. That would have been better, because touching both, you may spread the infection into the ulnar also. That risk I don't normally take.
Okay, sir.
I would not risk that.
Yeah.
Okay.
So these are the 2 months follow-up after the primary debridement. But sir, the patient still had a foci of osteomyelitis on the sequential X-rays, and there was continuous discharge from the wound. So with this picture, we again went for the second debridement, sir. And in this stage, we have done a sequestectomy. And again, the antibiotics, they were started according to the culture and sensitivity. So sir, 2 months after this second debridement, the patient has showed a decreasing trend of ESR-CRP. It was confirmed by counts and there was no active discharge. The suture site has healed completely. So at this stage, we have planned for a definitive fixation in the form of long 3.5 DCP plates and a tricortical strut graft iliac crest derived from the iliac crest for the defect in the radius. So these are the immediate post-op X-rays, sir.
Okay. This is a follow-up you have? You have any follow-up X-rays?
Yes, sir. Yes, sir. I have. These are the 4 months follow-up X-ray.
Good.
And this is a 6 months follow-up, sir. The tricortical iliac crest graft has been completely incorporated, sir.
Yeah.
Function?
Yes, sir. I'll do. So at present, the patient still has a small sinus with no active discharge over this radial wound, and the ulnar wound has healed completely. This is the flexion extension of the patient, sir. And as the patient already had a proximal radioulnar synostosis, so there was no pronation and supination for this patient. But the patient had a good hand grip and he is able to perform his courier and logistic services back.
Okay. Good
So
outcome.
some points are like, where did we go wrong exactly in this case? As we had to go for a second debridement. So definitely there was a suboptimal primary debridement. Then there was a question of inadequate stabilization after the debridement. So that's why we did not choose to put a cement spacer, because the patient was reluctant for an external fixator. And we have achieved a good bony union with the stable internal fixation after the second debridement, and there is a complete incorporation of the graft. So, sir, non-union of forearm bones, it is a challenging task, and there have been various methods described in the literature to tackle this. So these are the different methods. Most commonly, which we use as an iliac crest autograft, which has been described by Spira. We can use a vascularized fibula graft if we have a plastic surgeon standby, or a modified Nichols or Nichols technique. Sir, I like to quote this article, which is a case report. It is a infected non-union of radius ulna, which has been managed by Mangal sir only, sir. And in this, sir, sir has used a double-barreled vascularized fibula autograft. This patient also, it was operated somewhere else, and it got infected. So, sir, basically, what is the take-home message for forearm infected non-union is, as there's a good vasculature around the forearm, so non-union in the forearm is unusual, sir. So whenever we have a picture like this, then it is a disaster to manage. So the take-home message would be prevention is always better than cure. So a strict theater asepsis would be the best if we avoid first of all the infection. And coming back, sir, to the Mukhi sir's question, as he said, like he would have just opened the radius side. So whenever like we are suspecting a forearm non-infected scenario in a forearm, so always if we are opting for a debridement, it's better to approach both the incisions and check for an remote infection in the ulnar site, sir.
Okay. Thank you, Samir.
One more suggestion I want to give.
Yeah. Just let us ask Dr. Harshit to share the screen. In the meantime, you can give the suggestion. Can you just stop sharing, Samir?
Yes, sir.
The screen and Dr. Harshit, please share your screen. Yes, Dr. Mukhi.
I would have used a longer plate in the ulna and transgressed the ulnar screws into the radius, which would have acted like an infix for the radius. Because superiorly it is sinuosed, lower down it would have been sinuosed also. So past 3 screws, so that acts as an infixator for the radius.
Okay, sir.
Then you tackle the radius.
During one more question, Dr. Samir, did you take any samples for culture during second stage?
Yes, sir. We have taken the sample and it confirmed, or it was again gram-negative organism Klebsiella, sir.
No. Then post-operative, after doing the final fixation, while doing the final fixation, I'm telling you.
Sir, after final fixation, we have not taken, sir.
Yeah.
Like we have started the...
I'll just tell you one of our cases, it has a infected gap non-union of about 3 centimeters, both radius and ulna.
Okay,
we had done that cement dowels, everything, and it healed. And then we did the second set, and while doing second set, clinically it was looking all right, but that time also we sent the cement dowels also for culture. And in one of the cultures showed again that gram-negative growth of organism. Though clinically patient is doing so far well, but again it showed the growth of organism. So in those cases, we treat them with antibiotics again for 6 weeks after the surgery. And pray for God.
What was unusual, Mohanty, in this case was the size of the graft used for the radius, which was almost 4.5 to 5 centimeters of tricortical graft. Which got incorporated.
Yeah. Okay. Thank you.
In the technique which I have described, only graft and no plating of the radius would have served the purpose.
Okay. Thank you, Dr.
In this case, and there would have been no discharge.
Let's move ahead with the next case, please. Yeah, Dr. Harshit, please.
Good afternoon, respected faculty. Presenting a case of distal femur fracture non-union. Here's a case of 43 years old male.
Can you make a full slideshow? Play.
Yeah. Presenting a case of a 43 years old male who presented to us with complaint of pain and swelling over left knee following a high velocity road traffic accident. There was no other associated injuries, no wound and no distal neurovascular deficit. We investigated him with distal femur with knee x-rays. It showed distal femur intra-articular fracture with distal femur comminuted fracture. We got a CT scan done to see the intra-articular component as well as relation of the proximal and distal component. Here's the CT scan. We planned this patient for distal femur intra-articular reduction through a CC screw and bridge plating through the comminuted fracture site. We did not open the fracture site in our primary fixation. It was bridged up to the GT. This is the immediate post-op X-rays. Follow-up X-ray after 3 months of the primary fixation. There is no radiological progression after 3 months of the primary fixation. So the question is, what should be our next line of management? So this is 3 months X-ray.
Yeah, I use a Harm's cage medially through the same approach and put the cancellous graft, one operation, and I've shown Sangeet is laughing there. He knows it, my technique of Harm's cage in C3 type of these fractures with a big void.
Why Harm's cage? Because it provides a mechanical stability as well.
So yeah, both the columns get stabilized. This is like a tricolumnar fixation.
Why not put a fibula graft instead of Harm cage? Fibula graft along
No,
with
you will
cancellous
have to
graft.
take a separate incision and another incision on the fibula and a cancellous graft also.
Primarily, you would have done that?
Yeah, I've shown them many cases, 7 cases I've shown. I presented a paper. It is accepted and also published in just go Harm's cage in the femur. Sangeet knows it very well. Channa Saab appreciated so many times.
Okay.
I wish he was here.
Harshad, what is your opinion?
So this was not a puncture compound to begin with, was it?
No, close.
No, it was
closed
closed.
injury. So I would have tried to put that fragment which is sticking out anteriorly into the quadriceps. I would have tried to manipulate it with minimal opening and put it at least where the anterior cortex is. In my first surgery itself, it would have served as a kind of a pathway on which bone will grow. That may not have worked, but if it had, you would have saved a surgery. But here again, you will now require to put in large cancellous bone grafts because your plate is holding well. Your biomechanics are good. So I think just a bone graft in this area with repositioning of that fragment will help.
Would you have done primarily or right now you want?
No, not primarily. As I said, primarily I would have tried, primarily I would have tried to put that fragment back in place. And in this instances where I feel that, later on there is a possibility that the fragments are too loose and I'm going to require graft, I would not hesitate to put a cement block there. The idea of this cement block is to produce a kind of induced membrane. So whenever the second time I'm going to put in a graft, I know I'm going to put in a graft, I have a membrane also there, which will enhance the incorporation.
Subhranshu,
Yeah, Dr. Babulkar, sir, yeah.
after fixing this by LCP, at the end of 4 to 6 weeks, you assess the situation, and in case there is no callus, go down medially, put plenty of corticocancellous graft and stabilize by additional medial plate.
Okay, so graft with plating.
Yeah, commonly
So-
done at the end of 4 to 6 weeks.
So we have 3 options that we put a Harm's cage with bone grafts primarily, or we put only bone grafts now at the second stage, or we put bone grafts with the plate. Let's see what they have done.
So we operated this patient with medial augmentation plating with autologous iliac bone grafting. Intraoperatively, we approached through a subvastus approach. There was the voids that were seen on radiograph was all occupied with uncalcified callus intraoperatively. So we removed all the fibrous tissue and the fracture site was completely packed with autologous iliac bone graft. So this is immediate post-op X-ray after second procedure. This is 10 weeks post-op after second procedure after medial plate augmentation. And this is follow-up after 1 year of the second procedure. Patient has come to us last month only. It could not follow up because of the this COVID situation. He just followed up last month, and this is the present scenario. He's still with us in the follow-up. So the question is, what should be our next line of management?
Yeah, Dr. Jhunjhunwala, sir, please. Dr. Jhunjhunwala, sir, you wanted to speak.
Jhunjhunwala, sir, please. Sir, we can't hear you.
Can't hear you. Please unmute yourself. Yeah, Dr. Mukhi, please. Dr. Mukhi.
Unmute yourself.
Unmute yourself.
You will have to put that Harm's cage, and that I have presented in Katra Correlation. You go through it.
Yeah,
It's a
yeah, you
beautiful
have
technique.
already told about it.
Same procedure, yeah.
Right
you
now,
have to
you would
fill
like
the
to
void,
put.
otherwise your implant will fail.
Right now means during second stage you would have, instead of putting a plate, you should have put that Harm's cage with a bone graft. Okay.
Bone graft, yeah. That start with the graft.
Dr.
Jhunjhunwala, please.
Dr. Mohanty, at present the situation is we are not sure
whether it is going to fail or whether it is healing adequately.
Yeah.
You see about 50% of callus around in one of the cortices. The issue is that at present.
Dr. Monty,
Yeah, please.
such type of cases require always both columns have to be fixed. As you say that the pendular fracture of the humerus requires both columns to be fixed. Same way for the fracture of the lower end of femur requires fixation of both the columns. Or I do intramedullary nail, supracondylar nail, plus plate, plus bone graft, and which gives the best result. The importance of the nail is you have two plates, that with the two plates you can't ask the patient to walk. But with the nail and one plate, lateral plate with bone graft, you can allow the patient to walk faster. That is the advantage.
To start with, primarily you would have done that?
I have done about 12 cases and they did very well.
No, primarily, first surgery you should have done. Okay.
Primary nail with bone graft with lateral plate.
Okay, sir. Now, can you go ahead, Harshit, what you have done?
So the patient is still with us in the follow-up, yet to intervene the third time. We are just following up. He's walking with a support, but he's partial weight bearing.
You have any in the review of literature? What is the next line of management? Whatever is your plan?
So in the review of literature, I could just support our approach, addition of medial locking plate with in situ lateral plate in a healing of distal femur non-union. So in that they showed union in their cases.
Okay.
Mohanty.
Thank you. Yes, sir. Just while Mangal is sharing the screen, Dr. Harsad followed by Dr. Babulkar, please.
So these
Harsad,
cases
yes.
take a long time to consolidate. I feel 1 year is a short time after your grafting. You don't need to be very aggressive right now. Just keep it under observation, keep him non-weight bearing.
I think you had shown a case like this some time back. Yeah.
It takes a long time
to consolidate. Yeah, Dr. Babulkar, sir. Yeah.
I think 1 year is over. It's unlikely to unite. I would still go there, free the fibrous tissue, put an intramedullary fibula, and plenty of cancellous graft.
Yeah.
I've been waiting for some time.
Correct.
That is another option available.
Yeah. Okay. Thank you.
And
Sir.
that cancellous screw is long. Take out that cancellous screw. It is hurting medially.
Okay.
A couple of questions. Is this patient weight bearing now well?
I don't think so. He must be weight bearing. Dr. Harshit, could you answer that?
He said he's kept him non-weight bearing or.
No, he's weight bearing.
Chit, unmute yourself.
So I would make this patient weight bearing, number one. Number two, I would do a CT scan to see what are the areas which are unossified, because on the lateral, I can see what appears to be a callus bridge. Now, if that callus bridge is there, then I would venture to increase his weight bearing, to near full weight bearing. Also, I would check endocrine, vitamin D, vitamin B12, calcium, etc., and ensure that there is no deficiency on that point. And I would continue with weight bearing before I intervene, unless there is a lot of huge empty areas, only then I would consider. Otherwise, I think, as Harshad pointed out, this is likely to progress to further healing.
Okay. Thank you. You can go ahead with the presentation.
Okay. So this guy was an 18-year-old who came with a radial deviation and shortening of his left forearm. Elbow was normal. His pronosupination was affected with a pronation of 30 degrees from the neutral and supination of 10 degrees. There was no dorsiflexion in the wrist and 20 degrees of plantar flexion. He had a long history. He had a fracture in the 6th standard. When the nailing was done, removed after 6 months. He refractured in 1 month. And since then, he had no treatment. And this is how he looked when he came to us. The significant things were his radial deformity and lack of dorsiflexion. Over here, you can see his pronation and supination. The pronation here looks a little more, but if you look at the wrist, it is definitely limited. That was his X-ray. So radius is short for sure, and the orientation of the radial articular surface is abnormal. Now this was a stiff non-union in the sense there wasn't any mobility in the fracture. If you look at the area of the fracture, you will notice that there is no real atrophy per se. So you could say this is a normotrophic at the very minimum. So our plan, because the issue didn't seem to be one of biology, but issue more of alignment and stability, was to do a gradual distraction to lengthen and correct the deformity and restore the radius-ulna relation. Our experience with the Elizarov has shown that in these stiff non-unions, when you distract them, it forms bone. So the idea was we will distract it and see. If bone forms, which I expect, well and good. If it doesn't, then you can always go and do an internal fixation with bone grafting, etc. as required, because the radius is now out to length. So we put on the Elizarov frame. For the upper limb, it's quite convenient to put in shan screws. So we have 2 shan screws in each of the fragments. Important to ensure that they are sort of 90 degrees to each other. And we don't use standard shan screws. These are screws which, though they have a 6 millimeter diameter in the shaft, in the threaded portion, they taper from 4.5 to 3.5 in the tip. So these are specifically for upper limb or pediatric patients. And we require, really speaking, only 2 rings for the upper limb. So here, because there were multiple movements that had to be done, that is angulation, probably rotation and distraction, it's very useful to use a 6-axis system, which in our case is the ortho SUV. So instead of the regular 4 rods which connect the rings, we have 6 struts which are pointed out. And with the Elizarov being modular, we are able to add on this kind of a hand splint, because as we distract it, his flexors are going to get more tight and the wrist will tend to go into flexion. So using a splint like this prevents that kind of a problem. All 6-axis systems require computerized planning, because you cannot predict how it's going to move. Each strut has an effect on the other. So in this case, what we do is we do a gradual, a little by little, in probably 2 or 3 stages. So here you see the first stage of just distraction, so that we get the sort of non-union side disengaged. There is a yellow tracing over there and a red tracing. Yellow is the current outline of the distal fragment, and red is the outline of what will happen after the distraction has occurred. So this is first plan. Then this is the second plan. After the distraction, we are trying to correct it. And then the final residual correction in terms of both the AP as well as the lateral. So this is really happening in 3D, but represented on 2D X-rays. Once the deformity is corrected, in the sense that the radius is out to length, radial inclination is reasonably okay, and on the lateral it looks parallel, then we can take out the 6-axis and put in a regular Elizarov rods to make the frame more convenient. Notice here that rings are not parallel, and whenever we have rings that are not parallel, they need to be fixed either with what we call these double washers or hinges, so that there is no abnormal force. The force on the bone is pure neutral force. There's no sort of shear force when you use this kind of thing. Because we are using pins and the pins are put properly, there is, with the fixator also, the patient is functional. This boy was studying, I think, for his pharmacy, if I'm not mistaken. So he continued while we were waiting for this bone to heal. So this was his X-ray when the things were, when the rods were put in or the OSF was taken out. This is 2018 November. You can see that there is a gap. in the AP as well as the lateral. And this is in 2019 May, that is 6 months from the time that the OSF was removed. AP lateral and 2 obliques, very well ossified. After removal, we protect this with a brace, encourage him to do exercises out of brace multiple times. So at his last follow-up, which was a couple of weeks ago, he had a full supination of the forearm. Pronation was coming only up to neutral. Wrist dorsiflexion is neutral and palmar flexion has improved. So dorsiflexion hasn't improved as much as yet, but he is completely functional for his left arm. And that's his X-ray of the last follow-up, which was 25th of November. You can see good healing of the bone. He's free of the brace right now. He has no real functional deficit at the moment. So if he complains, then we will have to think of something to improve his rotation, if at all. That's his movement. So basically what we've done is, what has happened is his arc of rotation has changed. If you look at the above pictures, which are post-operative, and the lower pictures, which are pre-operative, same arc of pronation, supination, except that it's changed to a slightly different area. So basically, in stiff non-unions, whether in the lower limb or in the upper limb, it is the alignment and the stability which is important. And often these patients will have a deformity. So when you do a distraction to correct the alignment and then keep them in alignment in a stable system, they will throw bone. And use of 6-axis systems, you can correct length, angulation, as well as rotation without changing the hardware, which is what is required in conventional laser of this thing. And there is no impediment to function. Pin side care, etc., these are all issues which are related to technique of application of the fixator, as well as experience in terms of taking care of the fixator. They are not really, they can't be called as a problem of fixation. Thank you.
Thank you, Mangal. That was an excellent, and management of a very difficult case. Very few people use Elizarov in forearm bones. Dr. Junjunwala was one of the pioneers of Elizarov. Sir, have you used Elizarov in such kind of cases in forearm bones? What is your opinion? Dr. Junjunwala, sir, please. Okay, while he's coming to the mic, Sangeet, do you have any other alternative for this except Elizarov? You would have handled it in a different way?
Probably ulnar shortening would have been alternative.
Only ulnar shortening, or ulnar shortening along with fixation of the radius.
Yeah.
Okay. Maybe some radial lengthening as well.
Yeah, with could you have done with unilateral fixator like LRS type, doing a radial lengthening rather than putting Elizarov? What is your opinion, Mangal?
No, you see, that is there just to get it out to length. What happens is in the lateral also oftentimes there is some amount of angulation. Now, if you put in a unilateral, you will get it out like this, and on the AP it will look good, but this is not going to be that good. With a 6-axis or with an Elizarov, you can do this also in the lateral. You can do this in the AP. Then further you want to lengthen it, you can lengthen it. You can play around with it much better. So the point is, if you're going to go in a car, and you know how to use a Mercedes, why use a Nano?
So the question is, in a forearm where there are 2 bones involved, is it more difficult to get a correction using a 6-axis which is placed only in one bone? Does the other bone cause any sort of a impediment to the correction if there is distraction?
Not really, because you are manipulating that one bone, and while the fixator was on, I showed you, there is rotation around that, because the radio ulnar joint has not been kind of held, and the ulna was stable. So there is not a problem fixing that, or rather using the fixator and correction, as long as your fixation is stable.
Okay. Thank you very much. Whenever you require a multiplanar deformity correction, Elijah is the best choice, and that what Dr. Mangal can do. Let's move ahead with to Dr. Fayaz Menon's case. Fayaz, please.
Good afternoon, everyone. I hope everybody can hear me.
Yeah, we can hear and see you.
I thank Bombay Orthopedic Society and my host institution, JJ Hospital, to have given me this opportunity. My patient is a 23-year-old right-hand dominant with a computer sitting job who came with the complaints of pain in the right shoulder joint since 5 years, increasing since then, with restrictions of the movement since 4 years, exacerbated since 1 year. There's no history of trauma or comorbidities or fever, weight loss, or any other joint involvement. On examination, his right shoulder joint showed crepitus, and there was severe restriction of movements, as you can see here. Forward flexion almost half as compared to other side. Extension was fairly okay, but internal rotation, external rotation, abduction were almost half that of other side. These are the clinical photographs. You can see here flexion, internal rotation, abduction, external rotation. On X-ray, we found this kind of a picture where there were multiple ossified loose bodies kind of picture in and around the shoulder joint. We got the CT scan done, which showed multiple osteocartilaginous loose bodies, intracapsular as well as extracapsular along the bicipital groove and in the subcoracoid region as well. Posteriorly, there were less of them, but still inferiorly and posterior-inferiorly we found. There didn't seem to be any of the loose bodies in the subacromial space per se. We got an MRI done of this patient, which confirmed the diagnosis of synovial chondromatosis in this patient. We were just contemplating whether to go ahead open or arthroscopic, because I per se had not seen this kind of picture in a shoulder joint. We'd seen in around hip or around knee joint. However, we went into the literature and saw that these things are done. We kept the option of open synovectomy as well, but went ahead and did arthroscopic procedure for this patient. Now, this is a lateral decubitus position. We are viewing from the posterior portal. This is the right shoulder joint. So you can see this area is the glenoid and this is the humeral head. Here you can see the biceps tendon and the subscapularis tendon over there. Found severe synovitis in this patient. We excised majority of the loose bodies from the anterior and anterior-inferior aspect, and those loose bodies which could not be reached, we had to flip the portals and remove them through posterior or other portals. Those which could not be removed from posterior, because posterior portal you cannot make very big, so those which could not be removed had to be pushed forward in the anterior and anterior-inferior area, so that again we can flip and go ahead and remove them. Fortunately, in this case, all the intra-articular fragments could be removed, and a few extra-articular fragments were removed. We went ahead and did the synovectomy arthroscopically in this patient. There were no subacromial loose bodies in this case, and these were the loose bodies which were excised. There were about 28 to 30 loose bodies ranging from 3 millimeters to 3.5 centimeters, those we removed. These were sent for histopathology, which confirmed the diagnosis of synovial chondromatosis. This is the post-operative X-ray. Here you can see the removal of all the loose bodies in and around. So intracapsular and intraarticular loose bodies had been removed, but we can still see there are some in the subcoracoid region which are left out. The follow-up care was pain management as and how tolerated, and the physical therapy. This patient was just operated below the pandemic, and then we couldn't communicate. The patient couldn't communicate with us. When he came back, we found that the shoulder range of movement had been completely normal, as you can see here. These are the these are the recent clinical photographs of this patient. And this is the range of movement post-operatively.
Very good. Excellent outcome. Yeah.
So now my question to all the faculty over here, should this have been done open, or should this have been done, what we did was right?
No, I think arthroscopy is the best solution now for synovial chondromatosis.
Yes.
Any opinion? Yes, Dr. Mukhi.
Sir.
You will have to do synovectomy, otherwise this will recover very fast.
Yes, absolutely. I completely agree. That is why I said that after having removed these, we did the synovectomy of the joint.
Yeah.
Now, yeah, please.
Yeah, Dr. Mangal, your opinion, please.
I agree. I mean, this is one of my questions was, how do you prevent it from happening again? And for that, that's
correct.
what I said, that you have to do a complete synovectomy. But still, I think there is a slight chance of recurrence, or what?
Yes. So I'll just come to that. So there are several papers, those are given. However, because shoulder joint is the this synovial chondromatosis occurs very less in shoulder joint. There are a few papers in which meta-analysis of about 191 cases of chondromatosis was done, out of which only 5 shoulder joints were found. The other one had 95 meta-analysis of 95 cases in the previous papers, and out of which only 5 were there. So roughly 5 or 6% of the cases are found in the literature. So we couldn't find a large series of this, whether open is good or closed is good. I mean, arthroscopic is good. The proponents of open procedure say that arthroscopically you cannot go to certain regions like in the bicipital groove, and you cannot really go arthroscopically over there, or in the difficult areas where you can go. Maybe synovectomy might not be completely possible arthroscopically. This was the opinion probably pre-2010. However, now we are able to access almost all the areas, including subcoracoid region as well, which in this case, we honestly speaking, because this was my first synovial chondromatosis of the shoulder joint, so honestly speaking, I was slightly skeptical going in that area, putting my foot into trouble. However, if I feel that apart from one anecdotal paper where malignant transformation of this was seen, I didn't find that unless these loose bodies are intracapsular and they're going to go intra-articularly and trouble, we should go ahead and do something for those. Yes, but synovectomy is very important. So the salient points out of all the review of literatures that we found was because of this rare, as I said, now early diagnosis is important, but the patient in our scenario comes to us only when there is severe pain or severe restriction of movement, because there is no history of trauma per se. This is very important that these loose bodies should be removed, because otherwise they are going to damage. As Mangal sir asked, the recurrence rate with open approach is about 0 to 31%. I can vouch that the 3 millimeter loose body which was removed arthroscopically, it would be really difficult to go ahead and see that loose body in a shoulder joint in an open scenario. So after arthroscopy, the range of
Thank
movement can
you.
increase and we
Thank
do not
you,
too much.
Dr. Fayaz.
Yeah.
Dr. Junjunwala, your comments, please. Yeah, can you stop sharing your screen? And I request
Yes,
Dr.
Amit, are you the speaker?
Yes, sir.
Yeah,
Good
please
afternoon,
go
everyone. My slide is visible.
Yes.
I am presenting a case of pathological femur fracture. 18-year-old female presented with painless deformity and shortening of left lower limb. Since many years, there was progressive worsening of deformity. On examination, there was multiple swelling or left lower limb. There was shortening of 11.5 centimeter. Varus deformity was there. Knee range of motion was 0 to 60 degree. No neurovascular deficit. So this is clinical picture showing the multiple swelling over left side. So we did the X-ray pelvis with both hip and femur showing the multiple lytic lesion in the femur involving the metaphysis, diaphysis and involving whole femur along with the calcification. There was also lesion in the proximal fibula and distal femur and also in the distal tibia. Scanogram showing the varus deformity mainly in the femur. There was shortening of 11 centimeter, around 8 in the femur and 3 in the tibia. We did the skeletal survey, X-ray of the LS spine showing the lytic lesion in the vertebra and along with the calcification in the ribs. CT scan confirmed our finding of multiple lytic lesion with chondroid matrix. And also in CT scan, we find the hemangioma in the respiratory tract. So we did the MRI to see the extent of lesion. There was a lesion involving the metaphysis, diaphysis, wall of the distal femur, and involving the proximal tibia, and also is the distal tibia. So here question is, what is the diagnosis and what are the options of treatment? So should I proceed?
Multiple neurofibromatosis?
No, sir, there are multiple enchondroma with hemangioma. So this is non-neurofibromatosis. This is Maffucci syndrome. So what are the options of the treatment? There is two things are there. There is shortening and varus deformity. So we did the acute distal femur varus correction with proximal femur corticotomy with LRS and histopath examination confirm our diagnosis of enchondroma. Follow-up after 1 month showing the distraction at the proximal site and compression at the distal site. Follow-up after 3 months showing the resonate at the proximal site. So at this time, patient lost to follow up with us due to COVID, and 9 months at around 9th and 10th month, patient sent to us X-ray. In his X-ray, there was of the distal osteotomy site with proximal corticotomy site was consolidated. So we advise her to remove fixator and give hip ankle knee foot orthosis. So after 11 months, 1 month after the removal of fixator, patient presented to us with this picture with pain in thigh and inability to weight bear on the lower limb. And incidentally, patient diagnosed with granular cell of tumor of ovary, which respond very well to chemotherapy and radiotherapy. So what should we do now? What are the treatment options now?
Put in a nail and a graft.
Okay, sir, nail and graft. Okay. So we
And you could have done a lengthening over a nail.
Yes, sir. This was an option, but we put the nail and didn't graft this. We put the nail and didn't lengthening. So this is scanogram. Yes, sir. Scanogram showing the correction of deformity. Patient still has a shortening of 4.5 centimeter, which is in the tibia, some amount of 3 centimeter incision, and also in the femur. So this is clinical picture.
In the tibia also lengthening over a nail.
Okay, sir. This is video of patient. Patient is able to walk with the help of support and shoe raise.
Amit, is there any reference for giving bisphosphonates in such cases in pathological bones, especially in this kind of syndromes? If you would find.
Sir, I didn't find it related to Maffucci syndrome and Ollier disease. It is
Because the quality of your regenerate may not be as good as what you get in a normal bone.
okay, sir. Next. So we did review of literature. Maffucci syndrome is due to mutation in IDH1 gene, which is isocitrate dehydrogenase, a disorder that affects bone and skin. In bone, there is multiple enchondroma, and there is increased risk of chondrosarcoma. If there is 100% risk of chondrosarcoma, if you follow up this patient up to 40 years of age. On skin, there is a hemangioma, and these patients are at increased risk of cranial cavity tumor and abdominal tumor. It is IDH1 gene mutation is due to somatic gain of function mutation rather than loss of mutation. It is located on chromosome 2q. So we didn't find any article of lengthening in the Maffucci syndrome, but we find of limb reconstruction in Ollier disease, which is a kind of similar disease with less malignant potential. In their Madan et al. Series, there were 10 patients with mean age of 10.7 years, with minimum follow-up of 2 years. Mean length gain in their series was 42 mm. Mean time in external fixator was 164 days. Bone healing index was 32.5 days. There is tendency for osteotomy to premature union. So it is advised that start the dissection at early date at 4 to 5 days and start dissection more than 1 mm. Thank you, everyone.
Thank you. Case.
Yes, sir.
Arshad, can you comment?
Yeah, Harshad, your opinion, please.
Can you unmute Farooq Wadia, who has operated?
Sorry, there is a lot of background noise. I won't talk here, and I really wasn't paying attention.
Farooq is unmuted.
Yeah.
I'm unmuted. Yes.
Yeah,
I'm here.
Farooq, please, your opinion, please.
Yeah, so this case was done by me actually. So basically, we couldn't find any literature about Maffucci syndrome per se, but we found a lot of literature on Ollier's disease, which is similar. The only addition in Maffucci's is the multiple hemangiomas. And we did proceed with caution. So we were trying not to lengthen too much. And the literature was supporting the fact that the consolidation does happen sooner and it does consolidate well. And therefore, to answer Swapnil's question, there is no literature supporting the use of bisphosphonates in Ollier's at least.
Okay. But that was an excellently managed case. Dr. Babulkar, sir, have you come across such cases?
Amit, unshare your screen.
No.
Okay. Dr. Mangal Pariyar, your opinion, please.
Yeah, I agree with everything that Amit said in terms of the fact that, and what Farooq said, that these guys tend to ossify quicker. Per se, I don't have a case of Maffucci's, but Ollier's and Albright's I have dealt with. And they tend to sometimes heal quicker. We go through the chondral deposits or the chondral areas when we do the osteotomy in a deformity, and that has been shown to ossify that chondral deposit because of the process of limb lengthening. If everybody can just put on their cameras so that we could have a screenshot before the thing ends.
Okay.
Sandeep, Sunil.
Subhranshu,
Yeah,
I had
yes, sir.
similar patients, but was fibrous dysplasia, polystotic fibrous dysplasia,
Yogesh.
with them multiple
Okay.
deformities.
Okay. And Dr. Mukhi, you have any experience on this Maffucci syndrome?
No.
Okay. I think that was an excellent case that most of us didn't have any experience about that and managed also in a proper way.
Very well. Excellent.
Well done. Thank you. Excellent.
Yogesh,
Before
put on your
we
camera.
close in the meeting, may I have Professor Eknath Pawar's final, comments?
Hello.
Yeah.
Good afternoon, everyone. It was a very well conducted meeting, and it was very good academic feast for all the delegates. And I thank all the expert panel who have commented in this meeting. And there was very good support and comment from our senior faculties. Thank you, everyone.
Thank you very much. And Bombay Orthopedic Society is really grateful to Professor Eknath Pawar and the team of Grant Medical College and JJ Hospital for putting in such a series of a variety of cases, pediatric, spine, arthroplasty, arthroscopy, and everything was there. This was really, a platter of variety of cases and difficult cases which are managed, and problem cases also. So we thank all the delegates who have attended today's meeting from the beginning till end. It was constantly showing probably 100 and beyond 100. And more so, we are grateful to our expert panel today. And from the beginning till the end, Professor Sudhil Baburkar and Professor Dr. Junjunwala, he's there. And of course, our own team of faculty from Bombay Orthopedic Society, Dr. Mukhi is there always, to generate a discussion. And I thank you all for a great meeting, and wish you all the best. I close the meeting now. Thank you.
Subhranshu. Thank you.
Bye-bye.
Thank you. Thank you, sir. Now you can close the live.